It is my privilege this morning to read an acknowledgement on behalf of the School of Social Work, acknowledging the land that we are all gathered today on as original land of the Anishnaabek. I am Anishnaabek. Ozal Shashko Gijigukwe Indijnikas, Magizi Andorem, Anishnaabekwe Indao, Mede Indao. I'm a member of the Grand Traverse Band of Ottawa and Chippewa Indians of northern Michigan, and this is our land. So, miigwech, though, for being here together. This is the state of the world today, so you are all welcome here. And we love our neighbors, and this morning I have the privilege to read this acknowledgement on behalf of the School of Social Work. We acknowledge that the University of Michigan, named for Michigami, the world's largest freshwater system and located in the Huron River watershed, was formed and has grown through the connections with the land stewardship of the Niswa, Ishkudewan, Anishnaabek, the Three Fires people, who are the Ojibwe, the Odawa, the Potawatomi, along with their neighbors, the Seneca, Delaware, Shawnee, and Wendat nations. Miigwech. I'll turn it over to the Dean now. Thank you.
Thank you so much, and that's a beautiful tribute. I'm so happy we were able to make it, and with all respect to the people who lived here first, so thank you. Good morning, everyone. I'm Lynn Videka, Dean of the University of Michigan School of Social Work, and I'm very honored to welcome you to the 2018 Fidel F. Fauri and Iris M. Fauri Memorial Conference. This is an annual conference that focuses on a variety of topics in the field of child welfare, and the conference is presented annually to recognize our former University of Michigan vice president, but first, before he was vice president, he was dean of the School of Social Work, Fidel F. Fauri, and his wife, Iris. Fidel was a transformative dean. The University of Michigan School of Social Work is the leading school of social work in the nation today, and it's through the work of Fidel Fauri and through his vision that we are the school that we are today. So it's a great honor to pay tribute to his memory. We're also very pleased and honored to have Dean Fauri's daughter, Greta Fauri, Greta, hand up, and his niece, Lauren Fauri Thompson, Lauren, joining us today for the conference. Dean Fauri's leadership in child welfare spanned nearly 50 years, with much of the current social welfare legislation at both the state and federal levels being a product of his hard work and activities and his vision. He was first director of the Michigan Department of Social Services and then spent a number of years in Washington, D.C., where he held numerous leadership positions. His accomplishments in child welfare and social work education brought national and international acclaim to Dean Fauri, to the School of Social Work, and to the University of Michigan. Today, President Schlissel has announced, or he has recently announced, a major focus for our university, and that is engaged scholarship, for our university to be engaged with the people of Michigan and the people of the United States in action ways as well, and service ways, as well as research and teaching. And this really carries out the spirit of Dean Fauri. This conference is funded by gifts from the Fauri family, alumni, and friends, and is intended to serve as a forum for discussing ideas and proposals to enhance the well-being of children and young people. This year's conference is entitled Uncovering Substance Use in Families, a Child Welfare Lens. And its purpose is to draw attention to the growing issue of parental substance use and to share research insights and perspectives from a variety of interdisciplinary fields, including medicine, legal and court perspectives, parents and foster children's perspective. In addition to the presentations and discussion, we'll provide information on activities designed to promote healthy families. This year, we're very honored and very fortunate to have two eminent keynote speakers, Congresswoman Debbie Dingell and Dr. Fred Wulczyn from the University of Chicago Chapin Hall, where he is a senior research fellow. Congresswoman Dingell represents Michigan's 12th district in the U.S. House of Representatives. She's recognized as one of the hardest working members of Congress. She's made it a priority, and she has succeeded in that priority to be a voice for the Midwest on issues that matter most to working families. She is a member of the House Committee on Energy and Commerce and a leader on efforts to grow manufacturing, improve access to quality, affordable health care, to supporting seniors and veterans, and protecting the Great Lakes. Before being elected to Congress, Congresswoman Dingell worked in the auto industry for more than 3 decades, and as president of the General Motors Foundation and a senior executive responsible for public affairs. Please join me in welcoming Congresswoman Debbie Dingell.
Good morning, everybody. It's really an honor to be here with you today, to be here at this conference that celebrates Fidel and Iris Fauri and all the work that he did do. He really did. He did so much for social work and its credibility and recognizing the importance of it. And he really was a trailblazer for child welfare. And it's fitting that the university continues this conference in his honor. I also want to thank Lynn, Videka, the dean here, who does a great job and is continuing his work and the leadership that she does do of the school, and the fact that it is the #1 social work school in the country is something that all of you should be very proud of. And I also want to thank and recognize all of the students at the School of Social Work that joined us this morning. I applaud you for the work that you're doing, the studying that you're doing, and for your dedication to wanting to make people's lives better. In my opinion, social workers are the unsung heroes in our society. And we need to do more to get young people like you involved. I wish there wasn't as much need as there was, but there is. These have been difficult and trying times for our country, with many different crises making the headlines, and the opioid crisis has been at the top of mind for many. And that's why I'm really glad that you're focusing on this conference today, because it's a real issue in child welfare. I'm going to talk about it more in a few minutes. We've all heard the devastating statistics. Between 1999 and 2009, the rate of prescription opioid overdose deaths nationally has increased by 293%. Since 2011, deaths from opioids nationally have surpassed deaths from heroin and cocaine combined. Opioid prescriptions increased 41% in Michigan between 2009 and 2015. And in 2014, Michigan had a rate of 230 hospitalizations related to opioid use per 100,000 residents, slightly higher than the national average. So when you asked me to speak today, and when I saw what the subject was of this conference, and that you're highlighting an extremely important topic that doesn't get much coverage in the media on the impact of child welfare from parental substance abuse, I immediately said yes. It's a hidden and silent crisis in our country right now. Far too many children have had their lives and futures ripped away from them because their parents are addicted to opioid or other substances. And we can't forget the impact that the epidemic is having on children across the nation. Before I came to Congress, I chaired the 0 to 5 Early Childhood Initiative in Michigan. We've learned many things, and you're learning them in your classes from the work that's been done. But the most important thing we've learned is that those early years of a child's life are the most significant in their development. And those early years will determine what their future success is going to be. All children, regardless of their class, race, or income, deserve the same shot at success. And that means focusing on improving child welfare in those early years of life. Many young children now have parents who are suffering from a devastating opioid addiction that leads them unable to hold a job, unable to care for their children, or if you're in the household, as a child, you don't even understand what's going on. According to a report prepared by my colleague, Senator Joe Manchin from West Virginia, an estimated 12% of children in this country live with a parent who is dependent on or abuses drugs in school. In 2016, 92,000 children entered the foster care system nationally because of parental drug usage, the largest increase in 30 years. So I'm going to tell you why I know how much this matters. My father was an opioid drug addict. My sister developed a drug problem at a very early age, and there wasn't anything that I didn't do to try to save her life, looking for her, and ultimately we didn't win. And my 2 living siblings, my brother went as far away as he could from this state, and I don't think he's ever totally recovered. And my sister and I didn't talk about it for a long time. And we've become, my mother's still alive. So this isn't just my story. It's the story I tell is a story that impacts other people's lives. Some of you have probably heard me talk about it more. Because as we're talking about opioid drug addiction, we've got to start to take the stigma off of it and have a real conversation. My father, nobody knew in the 60s what prescription drugs were doing to people. The doctor probably did. You just didn't know what you were living with. I thought that it was normal for a father to stay in bed all day and stay up all night. I thought it was normal to have a father that thought that somebody was always after us and would have guns in the house and would actually sort of patrol the property. And in that paranoia, there were days when my father would snap. And I've told this story more in the last couple of years. And I know it makes it hard for my mother. And I say to my sister, are you okay that I'm telling this story? And she has said to me, Debbie, if we can help one other person, we have a responsibility to do that. And I remember, one night it was more than one night, but the night I remember the worst was when he snapped. And he threatened or tried to kill my mother. I tried to grab the gun. We all went and I called the police. In those days, the police didn't come. We were a prominent family in the town. They didn't believe that a man could be doing it. My mother ran out of the house and left us. My father took all the doorknobs off the door. And we just hid in that closet and prayed that we'd survive the night. My sister started first grade the next morning. My mother wasn't in the house. My father had, and I walked her to first grade. My sister never liked school. She never felt comfortable in a classroom. And nobody talked about it back in those days. Nobody talked about it. And I truly believe that that fight, which started the night before she started school, is what left her unsettled for the life that she had until she died. So I'm now I'm really, and as we talk about the opioid drug crisis, I think it's very important that we remember that there are people that need help too. You know, I talked to I live with a man. I've lived with both sides of it. I know what it's like to live in a household with a man who, look, my father was a good man and ultimately he got help, but I was never okay. I didn't speak to once my parents divorced. And I say to my mother, I want to tell you, I guess I'm talking about some things in this class that I've never talked about because you're social workers having to work. You're going to be social workers working with these kids. And I say, why did you stay? Why did you make us stay? Why didn't you do something to help us or rescue? And mothers get in these situations, or women are in these situations where they feel dependent or they feel stigma or they can't escape. And as you work with these families, you have to help them first of all, nobody admitted they had drug problems or alcohol problems in those days. We have to rip that stigma off. But we got a problem right now that we can't even get people into people that we don't have the healthcare providers. I was in Ypsilanti, and I was at a fundraiser for a child whose mother had been a school teacher, and I met two teachers there. One was a coach, and they were both retiring because their daughter was an opioid drug addict, and they have a 9-year-old grandchild and a 5-year-old, and they've taken custody. You all are seeing that more and more. But the 9-year-old was already drawing pictures with knife and blood dripping, and all they wanted to do was to get an appointment with a mental health care provider for their grandchild. And I was trying to be careful and polite. You know, social workers are a little more, you can ask some of the questions that I probably shouldn't, just like, could they afford it? Which I somehow got to without being that blunt. And it wasn't money. It was, you can't get an appointment at the University of Michigan with a child psychiatrist for months. I mean, I called people over here and there's a waiting list. You know, when you talk about the shooting that happened at Central Michigan University last year, I don't know how, it's not out there, but this is the young man went to the hospital that night. He went and asked for help. He knew he needed help. He had an opioid drug addiction. There was no bed and there was no doctor. So they called his parents to come help him. And because he was having an episode, he shot and killed his parents. I mean, we've got a real, you know, and I'm talking in classrooms now. I'm active in both Washtenaw County and downriver in the drug programs that are being put together in the schools. And what's interesting is that, last year they asked me to speak to 5th and 6th, 7th graders, which I thought was kind of young. And you could hear a pin drop. And I gave a little different talk, but I did talk about what it was like for me to hide in a closet. And the principal later told me that several children there identified with what I said about hiding in a closet. So this is a real crisis that I think people like me have to take. You know, people don't want to talk about it. They're embarrassed. It's a problem. They love your parents. Look, I loved my parents. I mean, I didn't realize how bad it was until I was 17 or 18. I mean, I just thought the life that I had was normal. But we have to do something. You all are doing it by training to be social workers and are going to work with these families. And we've got to invest more money in mental health. And we have to get more providers. And we have to recognize what the problem is so that we can help these kids. And we've got to help parents understand what they're doing to the kids. It's really hard. It's clear, so, it's clear much more needs to be done to address this emerging crisis. And if we don't act now, we could risk losing a large number of young people in this epidemic. So that's why you're having this conference today. There's been a lot of, and before I go back to my more formal comments, is at a university, you got to be good. I do want to say that as social workers, you also do have to recognize that there are people with real pain. Every time we have a hearing in Washington, I say to the head of FDA and the head of NIH, what are you doing to research non-addictive pain drugs? And that is one of the problems. My husband has terrible pain. He cannot move now without pain medicine. And quite frankly, when you're 92, you've got lots of problems. And so how drugs go through your system. So the only thing he can take is opioids. And we also need to recognize, so people are trying to do well-meaning legislation, which I'm going to talk about again in a minute. But when I go in the drugstore to fill his prescriptions, I get everybody talking to me. People feel like criminals. Doctors are having a hard time with the news subscription. Every speech I go to now, and I think because I do say we have to make sure that the pendulum doesn't swing too far, I have people coming up to me, and some of them are real, and some of them are people but cancer doctors are talking to me about how they're starting to have a hard time. We don't want to make people with real pain needs feel like criminals. We need to figure out how to help them. And that's another part of our whole crisis. So, but you did see, it's hard to believe anything good is coming out of Washington, but the president we passed a bipartisan bill. We worked really hard in committee and considered more than 40 bills that got melded into one bill. 4 of them were all bipartisan bills that I had done with Tim Walberg here or Fred Upton to respond to the opioid epidemic, and President Trump signed it on Wednesday. It's not a silver bullet. I want to make that really clear, but it's an important first step. And I was really proud that my Michigan colleagues and I on Energy and Commerce were able to work together on several of those, and I worked with some other Republicans on different. Fred Upton and I did trying to incentivize accelerating the work to find non-addictive pain medicine was one of the pieces of it. The Support for Patients and Communities Act also contains some important provisions on child welfare that haven't gotten much attention in the media. The law has a title dedicated to protecting pregnant women and infants. For the first time, the law authorizes HHS to collect data on neonatal abstinence syndrome and provide supports for states to collaborate and improve plans of care for substance-exposed infants. The law also increases the authorization level for the National Child Traumatic Stress Initiative at SAMHSA to provide direct service to communities and disseminate best practices in trauma-informed care for children and families. This is essential because the definition of trauma is changing in this day and age, and growing up with addicted parents who cannot take care of their children certainly qualifies as a traumatic event. We also direct the Secretary of Education to start a new grant program for local educational agencies to work with mental health systems in order to increase student access to evidence-based trauma support services to help prevent and mitigate trauma that children and youth experience. These provisions are just that small first step to address the issue of child welfare in the context of the opioid epidemic. And I will tell you that I plan and intend to hold this administration accountable to following the letter of the law and implementing these programs as Congress intended. But I will tell you that I think Kelly, believe it or not, yes, we all have weird relationships. Kellyanne Conway and I go to church together. And but you know what? I could go off subject about how we all got to start to build bridges and respect each other. We've got some I won't go too off subject, but she's taking the lead at the White House. And trust me, we talk about this more than you'll ever know. And while passing the Support Act in a bipartisan way was a critical first step, we still need to do a lot more to get people into treatment who need it. This crisis is on par with the HIV/AIDS epidemic. And in response to that, we passed the Ryan White Act and put real dollars behind clinics and treatment. Some of you remember it, some of you are young. And that's what we need to be doing on this opioid drug addiction. It's ultimately what is needed to help children and families treating the parents who are addicted. You know, I look at what I went through with my sister. And look, I'm the first person to say I'm luckier than 99 and 9/10 of the people, you know, in this country. And it's hard. You know, I can't tell you the desperation. I mean, she was in so many drug treatment centers. And, you know, this is, when you're dealing with real people and you're going to be dealing with this. So I finally got her to agree to and to go to Hazleton. I'd had her in a lot of treatments here, but she agreed to go to Hazleton. And I felt like, okay, this is it. This is finally going to be it. We're finally going to get, you know, and they called me within a week and said she had other health problems and she was making it too complicated and she couldn't stay. But they had made arrangements for her to go to another place that was connected to Mayo. And she walked out the door a week later. And she was dead in a month. I mean, there's sometimes you can't help anybody, but we got to do early interventions and help people before. Okay. Anyway, and we can't forget, we've got to make sure that, you know, Medicaid's got the dollars that they need. We've got to make sure that I'm somebody that I think every American's got a right to quality, affordable health care, period. That's who I am. And that getting good health care for these children at a young age and access to all of the support that they need is important. Medicaid's the single largest program treating people with substance use disorder in this country. And if we were to repeal that or reduce it as we go into this Congress, that it would have this single devastating impact on families across the countries in terms of access to treatment and care. We need to be expanding it. And if that were to happen, we would really be decimating what help is out there right now. So we can't take it for granted. So in closing, I want to thank you for everything that you're doing for our communities and for your families. This subject is so important. You can tell it's really real for me. And I talk about it so you can get the real world feel, but let's help other people talk about it. Let's get mothers when they're pregnant. Let's identify them with the doctors right then, that if they've got the problem, to give them help, to identify if their partner has it. We've got to do early interventions, and we've got to help give these kids an early beginning. So thank you for caring. Thank you for doing this. It's a really important subject. Thank you very much.
Thank you, Congresswoman Dingell. That was a moving presentation. I want to thank you for sharing your own personal story, your lived experience. And I want to thank you for your leadership, for not only in the Support for Communities Act, but in your broad vision for the importance of strong health care and focus on children. I do want to say that at the University of Michigan, we're working very hard on providing a leadership workforce in behavioral health for our nation. We're under Dr. Mary Ruffalo's leadership, we're the proud awardee of several HRSA, which is the Health Resources and Services Administration fellowship programs to educate behavioral health providers in an integrated health environment. So that means that the key to getting people help is not to make it a stand-alone, carved off, stigmatized mental health set of services or addiction set of services, but to integrate it into primary care, and especially for low-income families who are served in federally qualified health centers. So I'm very proud that we have that program here at the school, and recently got a special supplement from HRSA to improve and expand opioid use education for behavioral health providers. So we're proud to be part of the team carrying out the vision that you have. It's now my pleasure to introduce Dr. Fred Wulczyn. I'm going to tell you a secret. Fred and I have known each other since we were doctoral students together at the University of Chicago. And we each lived for a number of years in upstate New York, where we saw each other collegially and from time to time. And it's such an honor, personal honor for me to welcome him here to the University of Michigan. Dr. Wulczyn, rather, but I call him Fred, is a senior fellow and a founding staff member at Chapin Hall. I think you told me it's Institute for Children and Families at the University of Chicago. This is an amazing organization, an endowed organization that whose purpose is to provide a research and evidence-based knowledge base for child policies on children and families. Fred brings a diverse range of academic and public sector experience in the tradition of Fauri to his research. He was before the term was coined, Fred was leading evidence-based policies for children and families. It's his work, including some work that included the policies in Michigan that informed and shaped some of the most progressive ideas in child welfare services today. He served for a decade with the New York State Department of Social Services and helped shape the policies of New York. I know firsthand because we were collaborators with that department at the time I was at SUNY Albany. That's not an easy bureaucracy to work with. And Fred somehow managed to get the license and the freedom to do very original work. That was something quite to admire. His research focuses on child maltreatment and foster care. He's widely recognized for developing administrative data into a source of rich evidence that informs policy and practice. He has worked internationally in China, Ethiopia, Romania, New South Wales, and Australia. Dr. Wulczyn has received numerous awards and honors. He is a member of the American Academy of Social Work and Social Welfare, and most recently he was awarded an honorary degree of Humane Letters from Marywood University for his work on behalf of vulnerable children and families. Please join me in welcoming Dr. Fred Wulczyn.
Well, good morning. It's a pleasure to be here. I want to thank Dean Videka. 40 years is a long time, if I can say as much, but that is the truth. So we've known each other for a long time, and I'm happy to cross your path once again. I want to also extend a note of gratitude to the Fauri family. These kinds of forums that bring practitioners with researchers, policymakers, bring them together as I'm sure you understand, we are in an increasingly evidence-based world, and the opportunity for researchers to be informed by what's going on in the practice and policy world is an important part of that exchange. It's not a one-way street, it's a two-way street, and opportunities such as this one, where there's an endowment and a commitment to the long-term investment in the exchange between the academy and practitioners and policymakers is uniquely important for the progress we all want to participate in. And let me thank Professor Joe Ryan for extending me the invitation here. Joe and I have known, Joe's roots go back to Chapin Hall a little bit after I was there, but it's been a delight to develop a collegial relationship in the last couple of years, and I'm delighted to be here as a consequence of all of that. This is a particularly important issue, as you heard, Congresswoman Dingell. It's kind of hard to follow a presentation like that where there's such emotion, such real lived experience that everybody can relate to, particularly people who are committed to the issues as you are here at the School of Social Work. And so I'm a little drier than that. But I do want to try and build a bridge between what the Congresswoman said and some of what I'll be talking about, particularly as it pertains to the youngest children, kids under the age of 1. It's been an issue that I've been concerned about for a long time in terms of whether or not we as a profession, we as a society, pay enough attention to the unique vulnerabilities of children at the time they're born and the relationship between the child welfare system. And I think you'll see some things today that sort of are a step back to the larger picture, but are directly relatable to what you heard the Congresswoman talk about today. And so that's the goal here. So let's see here. So I've done my thank yous, a few disclaimers. I don't want anything I say here today to leave you with the impression that I don't think this is an enormous challenge and problem for us as a society. But I do want to step back and just say, okay, what is the problem? Because I think it's very hard to solve problems that you haven't defined. And so what I want to do is step back and say, okay, what do we make of the issues that were presented here today? The other thing I want to make sure that you understand is I don't want you to generalize from what I have to say and say, well, this is what's true in Michigan. What I want you to walk away with and saying to yourselves is, well, this is something we should know in Michigan. I'm going to be talking about one particular state. We have a relationship with this state where we help them understand the issues that they face. So it's one state. It might be the same story in Michigan or the other 48 states around the country, or it might be a completely different story. The issue is, what is your story in your state or in your county, as the case may be, as you'll see. And the thing that I want to do to try and amplify these points is to build a narrative, to start the story from the beginning and see what happens along the way. So, substance abuse is and has had a huge impact on the child welfare system. Child welfare directors, I know Stacie is here somewhere, live in fear of the next substance abuse crisis. When I started my career at in New York State, there were 17,000 children in out-of-home care. In New York City, within 3 years, there were 48,000, largely attributable to the crack cocaine epidemic. There was an $800 million budget deficit in New York State, and you could track almost all of that to increases in Medicaid and foster care expenditures in the state of New York for children in foster care and crack cocaine addicted families. So this is an extraordinarily important problem, and we are possibly today in the midst of a similar set of dynamics where the caseloads could grow rapidly. And the question is, how do we, as a society, how do our leaders in public and private sectors, how do we respond to this issue in a way that doesn't make matters worse? And I think that's the key ingredient. The issue of Congresswoman Dingell mentioned new legislation. There is the Family First Preventive Services Act that was passed in March or May of this year. And it sets aside for evidence-based interventions around substance abuse treatment. So there's a context, a policy context in play that we're talking about, but we need to understand more than the high-level statistics that arouse our curiosity, arouse our political will, but don't necessarily lead to interventions on the ground that are what we want to talk about. So I think this is a problem that requires some nuance, and I'm wanting to provide some of that nuance. And as I said earlier, what I am suggesting is this is something you ought to be concerned with in terms of the type of analysis, not the findings per se, but you'll make that judgment on your own. So the main issue is that if you go and look at your foster care caseload right now and ask how many of the children here today are because of the substance use of their parents, and you will find a lot of kids. I'll show you what that looks like in the state where we're working. And so naturally the question becomes, well, why is that true? Is it a volume issue? Is it if we go all the way back to the beginning of when those children first came into contact with the child welfare system, are we seeing vast new numbers of kids who are coming forward because of substance use? Or is it if you have substance abuse, the system treats you differently? Could be both. But if you have substance abuse in your history of allegations that brought you to the forefront of the child welfare system, do we somehow treat children in that and families in that situation differently? That it changes the odds that something will happen, and the something we're concerned here is, will they go deeper into the system? So is it volume? Is it changing the likelihood that something will happen? It could be both. But are we flooding the system and workers are trying to keep up? The issue of deeper involvement with the system is more likely when substance abuse, I mentioned that already. But we need to understand, what is the evidence? We want to be evidence-based in our decision making. Well, what is the evidence in terms of what's taking place? And I'm going to try and walk you through what the approach looks like. So we're going to, as I said, look at data from one state, and we're asking the question, what is the impact of substance use on the child welfare system, and has it changed in recent years? So we're going to create a narrative around a set of logical questions. What is the number of first reports for maltreatment? States deal with a large quantity of reports every year, but only a fraction of them involve children who are coming forward for the first time. There's a lot of families and children who are coming back to the child welfare system on a recurrent report of maltreatment, a reentry to foster care, and the share of new kids and families in contact with the child welfare system versus kids who are returning is an important issue when we ask this question about, well, what is the impact of substance use on the system? What's the proportion of first reports that involve substance use allegations? We would expect to see that number going up if the narrative, the general narrative, is true. What proportion of reports follow the assessment track versus the investigation track? So in this particular state, when you're reported, you can go down an assessment track, you can go down an investigation track. How many kids are going down one track versus the other? And what's the role of substance use when you get to that fork in the road? The system has to make a decision. Well, we're gonna assess the situation, see if you need services, or we're going to investigate. Well, at that fork in the road, what role does substance abuse in predicting whether you go down one fork of the road or another? What proportion are substantiated? So you get investigated, but there are decisions that remain to be made. What proportion gets substantiated? What proportion of investigations are substantiated? What role does substance use play in the likelihood that a child will be substantiated? And on it goes. What's the proportion of substantiated allegations that are placed? And of those kids who are placed following substantiation, what's the role of substance use? And then how do children leave care, and what's the role of substance use in their history as it relates to, will you be reunified? Will you be adopted? Will you go to a relative home? And what we're going to focus on are first reports. And you might ask yourself, well, why do we want to focus on first reports? And it's because everybody starts somewhere. And we want the narrative, the story to tell. We want that to be from the beginning. So what are we talking about here? So we're going to look at data from 2010 to 2017. It's sort of the sweet spot of the current situation. We're going to use age of child to add nuance. We're going to add geography as another way to add nuance. And we're going to focus on specific trajectories. Trajectories here being the unique sequence of events that a child experiences in relationship to the child welfare system. And what I've tried to do here with crazy little diagram here is to show the trajectories that we're actually talking about. So children at risk are in the middle. They get investigated, and then something happens. There are the kids in your upper left in the green box. Those are the unsubstantiated allegations. So there's an investigation. It's the first investigation. What can happen? Well, they might be unsubstantiated. They might be substantiated. I don't have the assessment track here, but I think you get the idea. Once they're unsubstantiated, they might come back. They might get placed. But this is showing all of the unique combinations of things that can happen. And these are all empirically observable in the data. There is a child or children who somebody follows each and every one of these pathways. And the question is, how many of these pathways are meaningful? What do they mean, and how do we interrupt the process that underlies the pathway, and what role does substance use play in this? So we're going to start here in the center, and then we're going to work our way down one pathway, and then we're going to work our way down another pathway to see how the narrative of substance use plays in determining which of the boxes will I move to next. We want to get this idea of, because what's important is that once you're on this branch of the trajectory map, you can't jump to this one, because it's basically always the unique trajectory that you're on. So all of the yellow diamonds with the little arrow next to it, those are all first placements in out-of-home care. So for the children on that particular branch, that's when they went into out-of-home care for the first time. But you can see that there is a variety of history that predates the first time a child went into out-of-home care. That right? So that's what we're trying to understand. How much history preceded the child before the first time they went into out-of-home care, and what's the relationship in all of that to substance use and other issues? It's not just a matter of substance use, it's a matter of other issues as well. So let's set the context. I said 2010 to 2017, there's been a substantial increase in the number of children in out-of-home care, from just under 6,200 to about 7,000. It's down a little bit in that 1 year, and then it looks like it's starting to rise yet again. But you can see, if just at the ends of this trend line, there are substantially more children in out-of-home care. So if you're a public child welfare administrator, this is the kind of thing that gets your attention. Now the question becomes, well, what's the role of substance use in this particular graph? And the blue represents July 1st of 2010. So we looked at the caseload on that day and asked how many kids are there on that day because of substance use. And December 31st, 2017, we stopped and looked and asked how many kids are on the caseload then and why are they there. We're interested in sub-mix. These are reasons for placement. We've had to group them together. So I forget what that one is. I think that one has to deal with housing. Neglect plus other allegations, but not substance use. Physical abuse only. Substance abuse, either by itself or in combination with other allegations. Sexual abuse. And then this is just everything else that's not there that we didn't put into a specific category to the left. And you can see that in January 2010, there were about 20% of the kids in care were there for reasons of substance use. And in December of 2017, that number was 45%. So that's a huge increase in the number of children in foster care. And it would appear that this is because of substance use. All right. So now let's go to the beginning of the story and see where we come out. And just to put the number of kids in out-of-home care in context, this now extends the time series. This is what we were looking at. And this goes all the way back to January 1st of 2000. So one of the important things to remember here, or to see, or to notice here, is that this particular state with 7,000 children in out-of-home care, they've been there before. So in terms of an increase, it's an important increase because public expenditures are going up, but the state's been here before. And so that's part of the context that we have to understand. What did the kids look like back in January of 2000? What did the number of kids, the contact coming in through that entire period? So let's just sort of step back and understand what it is we're looking at. I like to look at 10, 20, 30, 40 years of data to get some context, some historical context as to, well, we tend to focus on our unique time in history, but we are connected through these systems to prior periods, and it sometimes is helpful to understand what was going on during those times. So they've been there before. When you back it up, wow, that's a big change. When you put it in context, oh, okay, that's interesting. So let's, we'll hold on to that. We won't actually return to it, but I wanted to just sort of show you what history looks like. So you get one chance to make a first impression. And one of the things we don't spend a lot of time with when we analyze child welfare is this notion of inception. And that is the very first time either a single child or a family comes in contact with the child welfare system, because everything unfolds from there, right? Models that predict, so I'm in the business of trying to understand, well, who's going to come to the child welfare system. When you're trying to predict who's going to show up for the first time, you don't really need to think so much about, well, what's the system like? There are actually some things that you want to pay attention to, like the laws that govern who's a mandated reporter and what constitutes child abuse and neglect. So those things are important, but you don't really have to think too much about, well, what was the experience in out-of-home care? Once they've had their first experience and they come back, now you have to pay attention to their experience in the system, because they might have gotten good services, they might have gotten bad services, they might not have gotten any services. And so their experience now inside the system is different and has to be considered as we try to understand what's taking place. And you have to, in particular, take into account the efficacy of what was offered in the first instance. So we're going to look at first placement, first contacts, and then go forward. So what does that look like? Well, this is the data from 2010 to 2017. These are first ever investigations for child abuse and neglect. It's the same state. There has not been an increase in the number of child abuse and neglect investigations for the first ones. There has been an increase in the number of child abuse and neglect investigations, but an increasing proportion of the investigations they're doing are of children who are coming back. And I'll show you what might account for that. The yellow line is the proportion, or is the number of these first reports that are for abuse and neglect. So part of the talk here today is, well, how do we reconcile these two pictures? Because on the one hand, when I look at the foster care population, I see a burgeoning number of children in out-of-home care who are there for reasons of substance use. And so immediately the inference is, well, then there must be a corresponding increase at the system's front door. Because how else could you get from what you once were to many more children in a larger, it's a larger foster care population, and there's more kids there from families where there's an alleged issue with substance use. How do you get there if this is the picture of child abuse and neglect reports? So I'm going to tell part of that narrative. We're not going to get through the whole thing, but this shows you the percentage of all allegations that are related to substance use. Pretty stable across time. Anybody surprised by that? No, you're not surprised that it's a steady. All right, well, that's good. So I'm not, huh? Yeah. Again, first contacts. We're putting to the side anybody who's returning, because we want to know you get one chance to make a first impression. After that, the whole thing changes. So these are a little bit dense, but what we want to try and get to are assessment versus investigation by allegation and year, first reports. So there are two tracks, assessment and investigations. And then we're looking at time. And then these are abuse only, neglect only, other allegations. The one I have encircled are substance abuse only, abuse only, physical abuse, neglect only. And so for each one of the allegation types, what we're doing is we're trying to understand, well, what's going on below the surface. So first of all, you can see that the number of allegations for abuse only down the investment track, they're going up. So more kids are being moved onto the assessment track if there's abuse in the background. Neglect, there's a spike here in the number of kids on the assessment track in the 13, 14, 15 year. And the corresponding issue with that is that you can see there's a decline in neglect being investigated. So the system is, in a sense, trying to say what we want to move more children and families onto the assessment track because we don't think we need to investigate them, and that's part of the shift in thinking about how do you get services to vulnerable families. You don't need to investigate everybody, so we'll move them along. The important issue here from our narrative perspective is these are the substance use only cases. And you can see that in the 13, 14, 15 period, many fewer are going down the assessment track, and many more are going down the investigation track. So when I talked about that first fork in the road, assessment or investigation, the system is sending more substance abusing kids down the investigation track. All right? So same number, but the way we are dividing them and sorting them into cases that we have to explore. So substance abuse is figuring heavily in the decision making. I've got a family. These are their characteristics. Substance use is in their background. What do I do? I'm gonna investigate the case. I want to know more about what's going on. I'm not prepared to take the risk to the extent that there are risks associated with an assessment track versus an investigation track. I feel more comfortable going down the investigation track if substance use is involved. So although the top line number is relatively constant, the numbers below that, the nuance I was talking about earlier, is starting to change. We want to play out these changes over time. There's the substance use trend, and if you just take a quick look, you can see that a higher percentage of the substance use related allegations are going down the investigation track. So now the question becomes, well, if you go down the investigation track, what happens next? So just real quickly, this looks at urban and rural by age, because we're going to become interested in the age issue as a defining feature of what's coming in. So on the left are the urban counties, on the right are the rural counties. And you can see here that the age trends, there's really not a lot to make out when you're talking about 1 to 5 and 6 to 12-year-olds. There is, in the urban areas, a little bit of an uptick in the proportion of kids, or the number of kids who are in that age group. In rural counties, 1 to 5-year-olds on their way down, 6 to 12-year-olds pretty stable. The big news is the number of kids under the age of 1 is going up and has been going up persistently. All right, do you see that in the, I can go over there. Now you know why I'm not a brain surgeon. This is babies coming in. These are children whose first contact with the system is before their first birthday. Over there, that's the rural number. Now notice these are counts, and you'll notice that the bars are higher in the rural areas than they are in the urban areas. So now we're getting the idea that, well, this might be a rural problem as much as it is an urban problem, or maybe even more. And you can see that for the 1 to 5-year-olds, this top line here is not that different than the top line here, but here it's decidedly down. In rural areas, there are fewer 1 to 5-year-olds coming into the child welfare system for the first time. Well, one of the reasons for that might be we didn't wait till they were 1 to 5-year-olds. We got them when they were babies. So if you start acting on babies earlier, well, then their first contact won't be when they're 1 to 5-year-olds, right? Makes sense, but we don't often think about the connection between when we intervene with babies, then their first point of contact with the child welfare system can't be when they're 5 years old, because we've already seen them, right? All right. Oh, yeah, there we go. So again, just the increase. So now the narrative turns to, well, what happens if the decision makers on the ground floor respond to infants associated with a substance use allegation differently than they do when they're 6 to 12 years old? Because we're seeing more of them. And if they have a different likelihood of going further into the system, that might be one reason why the top line number isn't changing, but the stuff that's going on down below is in fact changing. Just to zero in on first reports by age, allegation type, and year. So now we're looking specifically at the intersection of age and allegation. And the one to pay attention to is down here, over here. These are children whose first allegation and report are babies. And the scale here is the number. And you can see that there is a huge increase in the number of children who are under the age of 1 coming into the system for the first time. There's a decline, and then it's back up again in 2017. But these are dramatically changing numbers as far as children of other ages and abuse only. It's a much more mixed story. We might want to talk about what's going on there with 13 to 17-year-olds. Abuse only, they're down, but a lot of these numbers are on their way down. So that's where the top line number evens out. Infants are up, older children are down. So what we see is a large increase, but now we're getting to the root cause of what's sort of underlying the issue. This just highlights it again, the age composition over time without regard to allegation type. And the axis here, I tried to make this smaller. I can't even read it. But I believe that's the percentage. Again, it just repeats, but it amplifies the point that on a percentage basis, the proportion of kids coming in for the first time is much more heavily focused on under 1s than it is older children. So there's a shift going on. So this just sort of adds it all up. Total reports. This is investigations versus all investigation or all reports. It includes all dispositions of the reports, assessments, and investigations. And just to highlight the point, 20% of first reports involve a child under the age of 1 at the time of the first report. We're gonna zero in on this. You can see sort of the preschool 1 to 5, 1st to 7th grade. You get an idea of the frequency with which children are interacting. So they have a substantiated allegation. What next? If you go back to the snowflake diagram, they're now in that one trajectory where the first thing that happens is a substantiated allegation. What's going to happen next? What are the possibilities? Well, nothing may happen. That's the only time we hear from that family as far as the official records are concerned. Or they might get services, and then there's a recurrent report, a re-report of maltreatment. Or they might go into placement. Point being is there's only one thing that can happen next. Recurrent report, nothing happens, or foster care happens. So what happens? Well, the interesting thing about it is that over 50%, regardless of abuse type, are never heard from again. So this idea of, lots of kids being re-reported, you really have to look very closely at that, because most kids, the first is the last contact. Now, it's important to know why, whether that was the right decision or not. Parents get a say in what happens next at this point in the process. Whether that's a good thing or not, hard to say. The blue line, I will deal with the orange one. I guess that's orange. That's re-report. And that runs at slightly more than 10%. But if your allegation type was substance use, it's closer to 18%. So it's almost twice as likely that if you don't go into foster care, you'll come back on a re-report. So this is the idea of, well, now we want to understand re-reports. What happened? What did they get? They weren't placed. But what services did they get? Were they offered services? Were they denied services? Did they refuse services? But the system is now part of the narrative in a way that it wasn't part of the narrative in a prior sequence of events. And then the one that we're interested in principally is the blue line, because that says what fraction of the kids with a substantiated allegation for any form of maltreatment, as it's displayed here, what was the likelihood that they would go into foster care? And the blue line, for neglect, it's actually higher than the other allegations, but substance use is also very high. It comes in at around 18, 19%. So there's a 1 in 5 chance that if you're the subject of your parents are the subject of an abuse allegation involving substance use, there's a 1 in 5 chance that the next thing that's going to happen is you're going to get placed into foster care. And that's higher than if it's physical abuse. It's on par with neglect. and for all of the other types of allegation histories. That is to say, you can have multiple allegations for any particular report, and when you look at the ones that aren't identified here individually, there's about a 10% chance that you'll be placed into out-of-home care. All right? So let's talk about the kids who get placed into out-of-home care. This is their profile by age. So of substantiated allegations, kids who go on, the risk of being placed, right, the general risk is about 10%. If you're under the age of 1, it's 20%. So now what do we remember about the population of children moving through the system? They are getting younger, and younger kids have a much higher likelihood of being placed into foster care following an allegation. So we're tilting the population towards younger and younger children. This is the actual age distribution of first admissions to out-of-home care. You can see that babies are a big part of the story. We talk a lot about kids and youth who age out, an important subpopulation. They pale in comparison to this group of kids right here. These kids use more foster care than any other population of kids coming into out-of-home care. If we think about this as a dose-response problem, the impact of being in out-of-home care is partly explained by, well, how much of your life did you spend in out-of-home care? Were you there for 3 months early in childhood? That's very different than 3 months as a 15-year-old. Were you there for 3 years from the beginning of life? That's very different than if you're there for 3 years starting as an adolescent. So we think about this as a dose-response problem. The kids whose lives are touched the longest by out-of-home care is this group right here. We pay almost zero attention to that fact. We've got little things around the edges of this issue in the child welfare system, but it's a very different narrative when it comes to, well, exactly what is the impact of this group of kids on the out-of-home care system? And you'll see this play out. Admissions to foster care by reason. 35, 36, 37% of the kids entering out-of-home care are entering out-of-home care for reasons of substance use. What that means is that if you have substance abuse in your background, there's a much higher likelihood that you will be placed into out-of-home care. And it shows up in the distribution of reason for placement among kids who've been placed into out-of-home care for the first time. Age at first admission by reason. Under 1s, the yellow bar is substance use. If you're under the age of 1, 60% of the kids coming into out-of-home care in that age group are there for reasons of substance use. You heard Congresswoman Dingell talk about the very young kids and the issues around infants and prenatal care and access to services among kids under the age of 1. This is why it's important. So it's a predominantly large group of kids in out-of-home care, and they're there for reasons of parental substance use. The likelihood of being involved with substance use goes down as the age goes up. Now, we want to spend the money from the Family First Preventive Services Act legislation. We want to spend it wisely. And so it would be interesting to think about, well, what could you do to prevent all these babies from coming into out-of-home care? And what are the evidence-based interventions? But the big question is, how much time do I have? They're born, they're reported, they're placed. Do I have 6 months? Do I have 9 months? Or do I have less than 30 days? So this looks at the blue bar pertains to kids who are admitted within 30 days of their birth. And the orange bar refers to kids admitted before their first birthday, but between the 31st and the 365th day. 50% of the kids who are babies and coming into out-of-home care with a substance abuse allegation are there within 30 days. So how much time do you have? How much time do you have to prevent the placement of a child into out-of-home care? You've got 30 days to make that caseworker comfortable with the idea that you're going to send that child home to that family. And if we wanted to look even more closely, 7 days is the magic number. So these are kids who are not going home when mom leaves the hospital. They're being placed virtually directly into out-of-home care. You've got 30 days. There are practitioners, evidence-based specialists here. I want to know if there's an evidence-based intervention that manages the problem of substance use so that you could actually curtail the volume of kids coming into out-of-home care within 30 days of their birth, because that's the biggest population. You want to have an impact on foster care caseloads, you better be dealing with the problem of kids under the age of 1. And if you want to prevent them from coming into out-of-home care, you better be talking to your Medicaid agency about prenatal care, smoking, list of factors that go on, their birth weights, on and on and on. But if you want to have a dent, that's where the dent is for a substantial portion of the population. Neglect, physical abuse only, this happens much later in that first year of life. So 30 days. Well, how does that play out? Well, before we deal with that, and just to give you an idea of people look at this and they go, oh man, that's just too complicated to understand. Make the narrative out of this. This is the narrative. You know, a colleague of Joe's and mine, Mark Courtney, he says, you know, when you've seen one child welfare system, you've seen one child welfare system. So what does that mean? That means that the child welfare director in the state has to figure out, well, what do I do in each one of my 12 regions, because the narrative is different in each one. You don't need to follow what's going on. What's going on in the details, other than in this county, it's a very different narrative, or this region of the state is very different than these regions of the state in terms of volume, in terms of the magnitude of change. What's the, you know, what shows up in this local newspaper that everybody reads is very different than what ought to be reported in this local newspaper, but this is the newspaper that sets the tone for the state. This is what we're dealing with. It must be what everybody's dealing with. So we come up with one-size-fits-all solutions, which is not to say that beneath the surface these same things aren't going on. But there's a very complicated narrative out there, and we oftentimes say, well, can you just make that simpler? No, we're not making it complicated. Life is making it complicated. So that's just 12 administrative regions. We've got to figure out what to do in a coherent way, where what we do in one place doesn't make matters worse in another place. Fine-tuning, precision policy analytics is what we need. So reasons for leaving care. Adoption, reunification, and relative exits. This is all children. And whether or not substance use allegations in the history of the child. So again, first report, and from the first report, did they go into out-of-home care as the next thing that happened? So again, substance use is here. Adoption, reunification, relatives. Neglect only, physical abuse only, and then the catch-all category. You can see that if you come into out-of-home care for reasons substance use, you have a 30% chance of leaving the system with a new set of legal parents. 30%. So when you're sitting down with mom, and mom's got the question, how am I going to get my child back? You can say to them, well, when we look at mothers like you, mothers and fathers like you, family like yours, there's a 70% chance that you'll, a 70% chance that your child will go to a family member or yourself, but if there's a 30% chance that they'll be adopted. When we talk about empowering families, do we have this conversation with them? You want the conversation, really, 1 minute, wow. When you have the conversation with your doctor about the surgery you just had, and you ask the magic question, what are my chances? How am I doing? You don't want the doctor to look at you and go, That is a great question. I wish I knew, right? But that's our conversation with our parents. What are my chances of getting my child back? We know the answer to the question, but we don't know the answer to the question because people can't respond in that way. So I have to speed along. Reason for leaving care by reason for placement, infants. The 30%, if you're a baby, it's now 50%. That you will leave the foster care system with a new set of legal parents if you were a baby when you came in. Reason for leaving care. Is this, oh no, I went backwards. Time to exit by age of admission, reason for placement. If you came in within 7 days of placement, your chances of leaving the system with a new set of legal parents is pushing north of 55%. There's less than half of the chance that you will get your baby back if that baby was placed for reasons of your substance use or substance use in the family. 57% chance that that child will leave the foster care system with a new set of legal parents. Nationwide, 20% of kids get adopted, 20% or less. But if you're in this particular category, 57%. Time to exit. So this is how long it takes to get kids adopted. It's actually all exit reasons, but you can see that if you're an infant and you came in 7 days or less, you're actually leaving the system to adoption, the blue bar, in less time than it takes for kids who come in to care as an infant, but after the 31st day. There's a big difference in length of stay. It takes longer to negotiate the adoption process if there's a chance you went home first, as compared to you didn't go home at all. It doesn't take as long for the adoption process to play itself out. What does that mean from a social justice? I mean, just think about the implications of that. If you commit substance use, we're going to be able to get that adoption done pretty quickly. And these are longer than the lengths of stay for other kids. Time to wrap it up. When we look at children in foster care, substance abuse is a significant factor. That's the first set of slides. But that narrative does not depend on a huge influx of kids at the system's front door. It may in your location. I'm not saying this is not necessarily what's true in Michigan. You need to know the answers to these questions. If we want to respond with effective services, we have to look at each fork in the road and say, who goes down the fork, one fork or the other, and what can we do to change the odds that something positive will happen for the children who arrive at that particular fork in the road. What we've seen here is that if you've got substance abuse, you're more likely to be investigated. If you have substance use and you've been investigated, you're more likely to be placed, particularly if you're under the age of 1. If you've been investigated for substance abuse and you're under the age of 1, you're much more likely to go into out-of-home care. If you go into out-of-home care and substance use, you're much less likely to go home to mom and dad and much more likely to get adopted. And if perchance you came in as an under 1-year-old within 7 days of life, then there's a really good chance that you will be adopted out of the foster care system. And from the stepping back, what does that mean about the society that we've created? Everybody's operating in this world. Their intentions are the best. But when we step back from the narrative that you heard this morning, powerful narrative, but now let's step back and ask ourselves the question, what does it mean for society when what we wind up doing is rearranging new legal families for all of these children, particularly those kids under the age of 1 that have been affected by substance use? And is that the kind of society we want to have? And if not, I think not, then how do we unravel this problem so that moms and dads have a chance, regardless of why they're in the child welfare system, but particularly if substance use is the issue, where there are economic injustices, social injustices, what have you? How do we unravel this puzzle? And I think it starts by understanding exactly what are the pieces of the puzzle and going forward in terms of constructing the narrative. So let me stop there and take any questions that you might have. Yes. Say who you are.
My name's David Adler. I'm a retired social worker graduate and worked for 39 years in child welfare sometimes, addiction sometimes, medical social work, part of the time, kind of mixes all of those issues up. So I don't have a completely coherent reaction to everything you said, but it raises so many questions because do we want that kind of society? Well, you ask. Okay. So how would you determine that? If we could ever figure out how to solve substance abuse, right? If we knew how to cure people of that problem, then everything would follow. Okay, right? So since we don't, how do you evaluate? Who are you supposed to look at? The kids, the family, the adults? Do we know if these kids who are adopted are doing great or are they doing harm? Do we know who these parents that never solved their substance abuse problem, did they ever solve it? How are they doing? And then what was the impact of having their child taken away from them? Did that traumatize them more and make their life trajectory worse or better?
Exactly.
So now that I'm retired, I'm so happy I don't have to think about it.
But you've articulated the issues very well. I mean, these are the questions. What's the value of state intervention? And how do you and is substance use the only risk that's facing these families, or is it just one of many risks? You take care of that one, but what about all the others? And maybe it's all the others that produce the vulnerabilities that generate the vulnerabilities to substance use.
Parents knew that if this is what you're going to do, this is what you're going to get, would it make a difference or not?
Yeah, hard choices. Thank you.
One of the things that stuck out for me in the data was when you looked at 1980 and the crack epidemic.
Yeah.
And the thought that went through my head was, yeah, and that was the war on drugs. And how many of those parents went to jail? And that was the reason for the change, and it wasn't just about the drug itself.
Right. Yeah, it's a complicated narrative even back then. But yeah, that's and how are we evaluating our social policies with regard to what actually are their impacts, and are we prepared as social workers to hear the answers to those questions that we're not necessarily going to like, because the reality is that the things we promote as policies and interventions that flow from that may actually not have the effect that we thought they would, because just the world's a complicated place. You don't always get a linear, this is a good idea. So let's, and obviously we'll get the benefit of that. Final question.
Behind you, Claire.
I don't need a microphone. That's okay.
Well, if you speak in the mic, then they can hear you in the other room. So
Appreciate. Okay, thank you. So for further discussion pieces, when you said you had the graph up where every place is going to be different, so would you say for future studies, do you think it makes sense to just have multiple versions of treatment? Does it have to be even trying to do one size fits all, or 5 sizes fits some?
So I think the answer to the question is not just what do you have, but how much of what you put out there is available, and how do you make judgments as it relates to the capacity of the system to serve a particular number of families and children. So I might not change the menu of services. I might change the quantity of those services that are available, tuned to the geographic area that you're talking about. And part of the issue is understanding, what is it about the policy context in the state and the kinds of investments it makes. Is there it's one thing if you find, you take two states with diverse policy frameworks. There's a tremendous amount of variability in the policy framework that states apply to the child welfare system. In the US, the states get to make it up in the context of an overarching federal framework, but their states are given tremendous latitude. So you take two states that have different policy frameworks, and you draw these pictures and you say, well, they're identical. The incidence rates, the probabilities that this will happen, that'll happen, in the context of these two vastly different policies, well, it raises a question of what's the role of policy. On the other hand, if you have one set of policies in one state and the picture looks entirely different, good, bad, not making a judgment about the valence of the differences as compared to another set of policies in another state, and the pictures are radically different, well, then you have to ask yourself the question, well, maybe the policy regime in one place is actually having a positive effect on what's going on. We do not do that kind of research in the United States. There's a tremendous amount of variability in states as it relates to, for example, what do I have to do to get a child adopted as the state? What are my obligations with regard to due diligence? Some states have 8 regulations that allow you to lower the standard. Some states have 27 regulations. Well, the fine people in those legislatures passed all of those rules for a reason. Do they actually get what they thought they would get, which would be quicker adoptions? The answer to the question is no, they don't. Because we don't think about the possibility that, well, if I add one more piece of legislation to what I've already got, it could actually slow things down, because now people have to think, well, is it this? Is it this? Is it this? What? And then by the time they're done thinking it through, more time has gone by. So it slows things down when the intention is to speed things up. We don't know the answers to those questions. And yet we continue to proliferate policy as though the next policy is going to have the additive effect that we intended it to have. Show me the evidence. I want to see that body of evidence, not a randomized clinical trial. I want to see the body of evidence that variability in state policy has an effect on child outcomes. So thank you very much for your questions. Great questions, and enjoy the rest of your conference.
Thanks to our morning speakers. I think both presented some powerful narratives. I'm Joe Ryan, a faculty member in the school, and one of the many planners for this particular conference. And so we're going to take a break now. I think, though, Fred, I know there's no more questions, but since I have this, I can at least make a comment. This notion that infants, children certainly under 1, more likely to be investigated, more likely to be placed, more likely to have their parental rights terminated, more likely to leave through adoption. I forget what it was, 60% of those kids. I'm sure there's some constellation of other factors, be it race, single parent, unemployed, that push that number up even higher. And so if we think about the types of families that are more likely to be separated permanently from their children, I think those are important concepts to think about. And whether this is our bias on substance abuse, like our immediate reaction that these can't be parents, right? That they are and unable to be parents in the long term. Whether it's a bias or whether these are good decisions being made is something I think we need to think about in child welfare.
So we're going to get started with our panel discussion. What I'm going to do is I'm going to introduce all of our panelists at once. So I'm going to give them a moment to fly up. Oh, people are going to sit at the table? You'd rather just sit where you are? Pardon me? Oh, so you can see PowerPoints. Perfect. Okay, well then we'll just do hand raising, all right? Yeah, there you go. Thank you, Sandy. So our panel is critical issues in assessment, medical, and cultural implications. And I was thinking in terms of preparing my remarks today and thinking again about the panelists that it is an honor to be here as part of this conference, and also that my name is Beth Sherman, and I'm an associate clinical faculty here, and I am just very, very happy to be at an event such as these, where there's a direct emphasis on practitioners and also subject matter experts. So people, as Debbie Dingell showed us this morning, people who have the lived experience of being a youth who've been and their family impacted by substance use. So I'm just happy to be here and have this continued integration. And after Fred's talk, I just was reminded of what's become my mantra this whole term. So I just have to read it to you. For every complex human problem, there is a solution that is neat, simple, and wrong. So, so I mean, Brad has thrown down the gauntlet for us, and here, and in terms of our practitioners, this is where we're at. We're trying to flesh out the complexity, the lived reality of our work. So there's how I'm setting the pace. Okay, so I do think that it's rather unfortunate that I only have 5 minutes to introduce such eminence. So I know, keep going, right, Sandy? Okay. So I will just introduce everybody at once, and feel free, of course, to delve into their bios that are written in the program. So we have, I'm going to introduce, first is going to be Stacie Bladen, and she is, there was a little last minute substitution, so sorry, Stacie. She is the Deputy Director of Children's Services in Michigan, and what I wanted to bring to your attention is that in addition to her current position, she also has 25 years of child welfare experience. So again, long history of doing the work. And I also wanted to note that in 2001, she was given the award as like the Future Public Leader Award in Social Work, and that was in 2001. So it's very exciting to see that they were right. Here you are. So thank you. So that's Stacie. The next person to introduce is Sandy Momper, who is esteemed colleague here at the University of Michigan and an enrolled member of the Bad River Band of the Lake Superior Tribe of Chippewa Indians. She, in addition to teaching and being a scholar, she's critically engaged with the American Indian Health and Family Services of Southeast Michigan. So is continuing to practice and to do that work as well. And also a co-principal investigator and evaluator of an intervention, Our Community Project, Native Connections, and Zero Suicide. Zero Suicide, it's a SAMHSA-funded grant. So when we were talking earlier about this concept of engaged scholarship, Sandy, right? Engaged scholarship. So here we are. Eva, I know you've already been introduced to us with your welcome and your acknowledgement in terms of the land that we're on and the people that have gone before us and are here today as well, Native people. So thank you for that. So Eva has 40 years of experience as a practitioner, working with tribal communities throughout the whole Great Lakes region. I wanted to just bring your attention to the fact that she's also an author of the Red Cliff Wellness Curriculum, which is a culturally based substance abuse prevention and community empowerment model that's being used in 130 schools and communities in the United States. So just to bring your attention to that curriculum, Red Cliff Wellness Curriculum. She's currently the program director of the Intertribal Council of Michigan's Anishnaabek Healing Circle, which is a statewide substance abuse treatment and recovery initiative involving 12 federally recognized tribes in Michigan, and is here to talk to us today about that work. So thank you. We'll also have Dr. Prachi Shah, who's coming again. Here at the University of Michigan, is an associate professor of pediatrics and is also a practitioner. One of the, in addition to many other roles in terms of the neonatal clinic and neonatal work, that Dr. Shah is our director of, is that the right word for doctors to say director? Okay, close enough. All right, thank you. Is the director of the Fetal Alcohol Spectrum Disorder Clinic here at the University of Michigan, which has been a very long-standing clinic, and I believe you've been here for 9 years in that role. So, this clinic has existed for a long time and has been a tremendous service to families and children throughout Michigan and the area. So, there's our introductions. Thank you. We're looking forward to it. So I would have been last, I think, with Doug York. Why? Doug asked me to come present in his place, as he's from Marquette. He's the Deputy Director of Field Operations for Child Welfare, and I'm the Deputy Director for Policy and Programs in Child Welfare, and he comes from Marquette, and so he's been traveling crazily all week, and I met him in Mount Pleasant last night, and he mentioned that he has to be in Ann Arbor the next day, and I said, let me go. I'll go do it for you. So this is on very little preparation, so I'm happy to answer questions that you might have specific to assessment in some other areas. What I thought I would do was really just level set sort of child welfare in Michigan and talk a little bit about our CPS and foster care areas of practice and policy, which really has an impact in how we respond to substance use issues in families and child welfare in Michigan. So first I want to see if we have any child welfare staff, whether you're with DHHS or a private agency here in the audience, or even someone who's getting ready to be in the field practicing child welfare. Okay, wonderful. So I want to just give a shout out to our folks on the front line. It is really an almost impossible task that we're asking of them every day. They're very courageous. They take their safety into their own hands. Many times I feel what stresses me when I go to bed at night is, how have we left our staff? Do they have the tools? Have we put them in situations? Have we created an environment that is going to keep them from being successful? And so I really want to give a shout out and a great big thanks to our staff here. And we appreciate so much at the department what you do for the kids and families in Michigan. I guess I want to start with where we're at in child welfare, and I'll talk about where we're at in Michigan as well. So we're well beyond the passage of the Adoption Assistance and Child Welfare Act of 1980, which was the law, federal law, that talked about making reasonable efforts to prevent removal and to then make reasonable efforts to return home. And unfortunately, we haven't made much progress. In fact, if you look at our outcomes since then, they are not any better. We're still bringing kids into care at a very high number, and the outcomes for those kids, particularly those who age out of the system, are not good. So why are we continuing to do what we do in child welfare the same way that the die was cast, many 30, 40 years ago, and we continue to do the same thing? It's very frustrating in child welfare to be part of something that is not helping families in a big way. And again, I lose sleep over those things every night. So we have a system nationally and in Michigan that's really, our system is here because of the funding decisions that the federal government makes. So if you look at federal funding coming to Michigan and other states, the great majority is dedicated to families and kids after removal occurs. We have over $1 billion budget in child welfare in Michigan, and significant majority of that money is dedicated only to serving kids after they've been removed or for adoption. And there's a need for that, certainly, but why do we do it that way when we could bring that money up front, incentivize services, effective service provision early on, rather than waiting until a crisis occurs or maltreatment occurs or a family is at extremely high risk? Stigma is there. Families don't want to come forward, and then we bring their kids into care. Why do we do that? It's not working. And so thankfully, the federal government, after many, many years of trying, and I know that there's some advocates here who've worked on at the federal level to change that funding imbalance, because we're basically sitting here in Michigan, like other states, saying, okay, we can only do so much. You're not giving us the funding we need up front. And so thankfully that shifted this year, and Fred alluded to it. That was a law that was passed earlier this year that significantly changes that funding imbalance and allows states to use those otherwise dedicated funds only for removal
up front. And we're looking forward and planning in Michigan for that. I will say that much of our ability to take advantage of that is going to be based on state administrators and what they decide to prioritize. And by that, I mean the legislature. And so we are going to work very, very hard to take full advantage of what the federal government has allowed us to do. And I won't personally lobby because I can't, but we will push in the direction of having our state appropriate the monies that we need to fully realize the benefits of that federal law. So let me just level set really quick, and I want to talk about a couple things, CPS and foster care related to substance use and where we're at in Michigan. But first, I need a little bit of context to provide you with a little bit of context. We have confirmed our confirmed victims in Michigan of child abuse and neglect is rising, and it has been rising. So back in 2015, we were at about 35,000. In this year, 2017, we're at 38,000 confirmed victims. Majority of our victims, 51%, are 0 to 5, and I think that jives with the national picture that that was provided. We do in Michigan have, well, I'll be careful how I say this. We, at one point, about 10 years ago, had close to 20,000 kids in care. We dipped down to about 12,000. And now we're inching a little bit up. We're at about 13,700 kids in care, which is okay. We haven't spiked back up like some states have with the opioid crisis. So we've kind of been holding our own in that regard. I'll say that, you know, kids who come into care make up about 0 to 5 make up about 40% of our kids in care. I was happy to see I follow it because that was funny when he said state administrators look at this data. We do. And I was really excited because we dropped about 200 or 300, between 200 and 300 kids entering care last month. So I watched that really closely. We were about 7,000 a year. And so we were just under 7,000 this past year. So it's stuff that we watch, and I constantly ask myself, what can I do with regard to policies and training that will help us in Michigan achieve our goals? And our goals are to prevent removal and to really help families stay together with meaningful interventions and services, to shorten the length of stay for kids that do come into care. Our length of stay for reunification is about 13 months. For those that are reunified, we can shorten that. Our length of stay for kids who have another permanency plan is about 24 months. That's the time that they spend in care if they're going to be adopted or guardianship or something else. Way too long for kids to be in care, because when they are in care, they're bouncing from home to home sometimes, and we are adding to the trauma that these kids experience. So we want to also increase the percentage of kids reunified in Michigan. Right now, we're at about 53%. That number makes me crazy. 53% of the kids that we bring into care are going to be reunified. The rest are going to have another outcome. So what can we do in Michigan to, instead of waiting till the crisis happens and putting kids in care, move the system much more to the front end? And so this next year is exciting for me. It's exciting to be in child welfare, to be part of that, what I see to be really a shift in where we should be going in child welfare to support families. So let me talk a little bit about what we've done in CPS, because policy does matter with regard to kids. How we're responding to kids who come to the attention of CPS and when we're putting them into care. And so up until about a year ago, first of all, let me start by telling you the child protection law requires mandated reporters to report, pick up the phone and call the hotline if you have any reason to believe or information that the child was born affected to a substance. They don't have a choice. It has to come into CPS. And they can do other things, but it has to come into CPS. And so up until about a year ago, we had a centralized intake policy that said, we're going to assign all of the complaints, even if there's not evidence of substance affected infant, but if the mother happens to admit that she, during labor or delivery, that she had used at some point during pregnancy, we're going to assign those complaints for investigation as well. So we stopped doing that. I think sometimes we over the years, we layer on policy, and what I saw was much more of a punitive approach with our policies. Why are we doing that without any information about parenting ability or resources that that parent might have to parent? It's, and so we stopped doing that. That cuts off sort of the folks that are, or the cases that are being assigned for investigation. We just this year changed significantly our CPS policy related to confirming child abuse and neglect. So prior to this year, we had a policy in place that said if you have an investigation and the mere existence, you've confirmed through medical tests that the child is positive, toxicology equals child abuse. And so we were confirming each and every one of those cases where a child had a positive toxicology result. No. Child abuse and neglect needs to be based on the parenting behavior, the parent's ability to safely meet the needs of the child. And so toxicology does not equal child abuse. I think that it was well-intentioned. There was a movement for some time to protect and keep kids safe. And by golly, if they're prenatally exposed, that's child abuse, and we need to sweep in there. I mean, oftentimes that led to removals. So we stopped that policy just this year, and I'm real eager, Joe, I'm looking at you because you hold a lot of our data, to see what our picture is going to look like after that's in practice for a while, and see, does that decrease the number of kids we're bringing into care, particularly our little ones, those are our infants, as a result of this new policy. So I'm going to be real interested to watch that. What do we do if we don't want to respond in a way at CPS by bringing kids into care? We have to have effective interventions at the front end. One of the beauties of the merger, if anyone knows about the merger in 2015, where DCH merged with DHS into one big 14,000 person department, one of the benefits of that was that we are now sitting at the table with our substance use partners who were over in the former DCH. We're sitting at the table with our population health experts and our mental health experts. It has been so significant to be able to have them at meetings, build relationships, and say, how can you guys help us with our child welfare problem? Because it shouldn't be our problem. It's not. It should be everyone's issue. And certainly, if we mean to intervene with those families much earlier, we need a population health approach, not a crisis-driven child welfare approach that can be very punitive. And so I mention that because we have a wonderful partnership now to apply home visitation services, evidence-based services available to families who are on Medicaid, and we have other programs that can get into the home and assist families early on, and they can do it for quite some time. 9 visits is typical. But if a family has a substance abuse issue, a substance use disorder, they can add 27 visits onto those. And so if we can get families right at birth hooked up with those sorts of services, we can prevent the escalation and the increased risk. And now it's a child welfare removal. Super excited about that. Somebody mentioned the Comprehensive Addiction and Recovery Act, which is super important. This is something that passed a couple of years ago, and we are working with our partners to implement it. And basically it says when an infant is born substance affected, the state is responsible, whomever it is, the state is responsible for putting together an infant plan of safe care. Okay, and that gets out real quick ahead of the problem and says the plan requires that the health and safety needs of the infant be addressed, the treatment needs of the mother be addressed, and the broader needs of the family be addressed. Because often we know that substance use doesn't happen alone. Families are multi-challenged. They have co-occurring issues. There may be a poverty issue, a transportation issue, concrete needs. And so this is good because it allows various professionals, not just child welfare waiting for a complaint, to really get involved early on in a meaningful way and help to support that family to stay together. And so we're working cross systems in a really wonderful way with our maternity folks, our population health folks, our home visitation folks, our family preservation folks, to do those infant plans of safe care that is not punitive, that encourages treatment and supports that families need. let me, how much time do I have? I'm sorry? Oh, okay. Let me take a drink of my mouth. I'm sorry if I'm talking so fast. It's been a long week. Another area certainly is foster care. When we do bring kids into the foster care system, again, I mentioned we're bringing little kids in, little kids who are at a critical time in their development who can not afford to have instability of caretaker. What we're doing there is we are adding to the trauma and reducing their chances of having a successful outcome. And so if we can keep those kids home or get them home very, very quickly to their primary caregiver, that's what we aim to do. I mean, so one of the things that we're encountering, and I'll give you an example in the system in child welfare, is that certainly there's a stigma associated with substance use. And the clock for permanency, as many of you know, is different than the clock for recovery and treatment, which is much, much longer. And so what we were seeing happen, and we're still seeing happen, is that we bring kids into care, and you know what, parents just can't get it together in the 12 months we need it to. Maybe there was a relapse or something else happened, and so we're going to go for termination of parental rights. Well, you can discount all of those families then, because treatment doesn't look that way. Treatment is a much longer process where there will be relapses, and parents need a significant amount of support in time. It's a lifelong approach in terms of treatment and recovery. And so, we started asking the question in child welfare, well, what are our workers doing to help reunify those families, or to inform courts or make good decisions about when they should reunify those, recommend reunification of those families? Because what we were seeing is that they were repeatedly requesting termination of parental rights. And what we saw when we looked at those cases is that there was a bias and stigma towards the use of medication-assisted treatment. In some courts, we've had to intervene with the state court administrative office, because we were seeing, and I want to preface it by saying we have wonderful partners in the judiciary. So if we have any of them out there, we appreciate your partnership. And so this isn't by no means to implicate, across the board problems with the judiciary. But I will say that what we were seeing was a tendency to want parents to be sober. Clean and sober. That's kind of the way we've done it for many, many years. Got to be clean and sober. Can't get the kid back. I've even gone to our workers and say, I don't care if they're drunk when they're in visitation. The kid's probably seen worse. Keep them safe and go on with the visit, as long as it's not harming the kid. There are things we need to consider, because these families are going through treatment, and this is their lives, and they're going to look this way sometimes as they struggle to heal. And so what we were seeing was judges saying, well, you're going to have to get off medication-assisted treatment before we're going to reunify. Or they would order them to taper back. Until I see tapering back, we can't consider reunification. So dangerous, and counterintuitive to what the research shows. And so we've been working with that to help educate our staff as well as the courts, so that they understand that this is a lifelong process, and that medication-assisted treatment is fine, and that the decisions about whether to reunify need to be based on adherence to treatment and their parenting ability. So how are they doing in every other aspect? They may have a relapse. In fact, I had one case, I won't mention the county, but I actually watched the transcript of the court hearing, in which mom of a 5-year-old, the 5-year-old had been in care for about a year. Mom was in treatment. And this was about another permanency planning hearing around 18 months, way too long, but it was around 18 months. And the worker said, I can't recommend reunification because mom hasn't tapered off the MAT. And so they put the mom on the stand, and mom's attorney asked, how are you doing in parenting time? And she said, I've been at every appointment for the past 12 months. Parenting time looks really good. How are you doing with your case service plan? She said, it's going great. I've had a stable house for 12 months, and I've had employment, good standing for the past year. And so went through all of the things that really measure parenting ability, stability, ability to function in the community in a productive way. And then the worker said, but I can't recommend reunification because she's still on medication-assisted treatment. And I mean, just about, and our poor staff, I immediately said, what are we doing? We need to get the word out. I mean, we can't have this kind of practice. And so that's like panic. Get the word out. And so, we're working on that training and cross systems training to help judges and our staff understand decisions about reunification in the context of substance use disorder need to be based on parental adherence to treatment and all of the other factors, and to help them understand medication-assisted treatment, and that is the preferred gold standard, one of them for opioid addiction. And so, and so we're doing that. I know I have just a couple of minutes. I want to just say a couple of things as I close. We do a reunification day every year, which is one of my favorite events, and kudos to Mary Beth Kelly at the Supreme Court because she hosts it every year. And we started about 3 years ago because we said we really want to celebrate families who overcome so many challenges and reunify with their children. That should be celebrated, just like we do Adoption Day, which is certainly worthy of celebration as well. But one of the things, what we do when we have the reunification day is we bring families in and we congratulate them and we celebrate them. And I have to tell you, the 3 years, and I've spoken at every single one of them, we hear from the families and they say the same thing. When we ask them, what was it about the intervention or the system that helped you? And every single time they talk about their relationships. And so, right. So, yep. And so we can apply fancy treatments. We can do all sorts of assessments and predictions and things like that. And I'd say this to our staff too, if you do anything, build relationships with people because that gives them hope. That tells them that they're worthy, that you care about them, that you think they can do it, and they will do it. And so that's always sticks with me because there's so many challenges that these families face. And if we believe in them and we give them hope, what a wonderful thing to be able to get their kids back because of that. And so I just bring that up just to kind of keep with you. I think it's one of the most important things we can do, and every single one of us, regardless of our education or our position, can build those relationships and give hope to families. So thank you.
Oh, here's your purse. Oh, okay, that's yours. Okay, so it's interesting. She ended up with medication-assisted treatment because that's where I'm going. And so Eva and I are doing this together, and this section, and we both came up with a whole bunch of slides, and we realized we had. Thanks. That we had all this data, and then we were like, wait a minute, we included it in the packet. So let's move away from that, and let's really focus on the voices of our community. So our presentation, I'm going to start, mine is going to be focusing on opioid use disorder and medication-assisted treatment. And then Eva is going to take over and talk about some of the projects that where she is actually involved in indigenous healing approaches. And then we have some digital stories to tell, and they're more focused on alcohol at this time, but there's a large percentage, and she'll tell you that of people that are also needing opioid treatment. So I'm going to rush through mine quick because we only have 25 minutes. We want you to see these stories from our people. So I know you've seen this up here. So I'm reporting on two things. I was invited to a NIDA meeting in May 2017 to look at, and these are all the people present, to look at what are the barriers for implementation of medication-assisted treatment among American Indians, Alaska Natives. And then on top of that, I also did 3 studies on my reservation, and it came to the forefront that many people were on Suboxone, and that they had some issues with it, and were wondering. And so
this is basically going to be their words, the words of people at the NIDA meeting, and then the words of community people. And this is kind of my pet peeve, MAT, because I really am more focusing on indigenous healing approaches. So it's interesting that I followed up with her. So views on opioid use disorder, the impact on families. So this is a service provider, and she said, I've been trying to keep an eye on everything, but that's how my granddaughter ended up eventually losing her kids. I have custody of them. The same service provider talked about her son also using, and how she had to take care of her grandkids, but at the same time get her son to meetings that he needed to get to. And she said, I'm really overwhelmed because I want to help him so he can also get his kids back, but then I also have to watch the kids. And then this is a young user. I had a focus group that was of all American Indian women who were using opioids. And she said, I'm going to school, I was supposed to graduate, but the pills and stuff, I just didn't go all the time when I had pills, and they messed me up. What's interesting about this group, too, there were 3 generations of women in there that were using opioids. And then a foster parent at the NIDA meeting said that, and at this point she has 6 children whose parents were, it was because of opioids. She had 8 at one time, and she mentioned that pregnant mothers on Suboxone either miscarried or babies had to detoxify from Suboxone, just like they had to detoxify from opioids, or they died shortly after birth. And so the challenges, American Indian researchers said, should I stand back further? You're okay? Okay, we want to know how to get people off of medicine and get people back to who we are as American Indian Alaska Native. No way in hell are we treating medicine with medicine. Withdrawal was worse than withdrawal from other opioids. And they were talking about the withdrawals from Suboxone. So you're just substituting one drug for another. I can't understand the medical model. They're saying, well, we have this abuse, and why treat it with another, with the same thing? And this was a service provider on my reservation. And so they really question the long-term use of MAT versus complete healing and abstinence, and more of a holistic intervention. And then some strengths. It prevents the withdrawal, and because getting off, it's a horrible withdrawal. And then it gives people a chance to start making some sense of their lives. They also need to get into a program and develop a lifestyle and go to AA meetings. And then a prescriber a non-American Indian prescriber at the NIDA meeting was incensed by some of the perspectives of the community people and said, well, pregnant women on MAT engaged in more prenatal care had better birth outcomes. So they shared success stories of using MAT, and one shared his integration of MAT into healing traditions, which I am more of a proponent of. So, and this is the group of the women that I met with that were all using opioids. I'd like to see a center where there's apartments on the res and have our workers and mental health caseworkers there. My reservation is really far from inpatient treatment facilities, so therefore their children have to go with relatives, and they recognize that burden on the relatives. And so they wanted something there. We have a domestic violence shelter there, a house. They wanted something that people would see in the community. We have this place. You can go there. The kids can maybe be next door in another house. I'd like to see something like that, Indian culture and spirituality done closer. That would be ideal to have on the reservation. And then another one said, when we go to the AA meetings, the treatment groups, it's always about substance use. Why can't we learn a skill we haven't learned? Why can't the elders come? Can't we learn to braid sweetgrass? Now, I think the next slide, yes, the next slide is where Eva's going to come up and tell us about her own perspective, and then share she'll tell you a little bit more about this, the digital stories of people. And I think it's really important. The reason I included all these quotes is that I really think it's very important in the work I do. It's mixed methods work. I have some quantitative stuff, but the stuff that the people are saying to me is really important. What are they saying? How is it impacting them? It's their voices, and that's very important to me. Now, Eva, your turn. Tried to be quick.
It does seem as though we're running a little behind. I don't want to cut into your time. Is this okay? Because we have about 18 minutes worth of digital stories. So I'm going to make my comments pretty short. Well, first of all, I have to say something about the child welfare system's relationship to American Indians. Some of you have probably studied this, many of you maybe have not. But we are probably the only population in this country, maybe there are others, I think probably there are, but where we have been historically removed from our families and separated from our families without cause, without assessment, and without intervention. And this is part of not only our ancient history. I'll give you an example. My mother attended the Mount Pleasant Indian School in Mount Pleasant, Michigan, when she was a child. So she was born in 1915. She attended there probably 1920, 25 in that time period. Her mother, my grandmother, attended the Carlisle Indian School in Carlisle, Pennsylvania in the late 1800s, 1889. She went there and stayed for 5 years. She arrived when she was 13, stayed till she was 18. So this is and there was no cause for removal. It was just the policy of the United States government because our families were inherently seen as unfit to raise our own children. So this country has a long history of failed policy, and we're making progress. That isn't happening now, but we still have a very high rate of children who are removed from our families. And I did appreciate the very analytical approach to that this morning, because I think it is important to look at what's really going on there. So I know I wasn't going to go off into that. I couldn't help myself though. So talking about our current work, I have worked in the field for about 40 years, field of substance abuse, treatment, prevention, recovery. I'm a person in long-term recovery myself. I've been sober for about that same period of time. So it'll be 40 years in February of this coming year. So, and I have many stories to tell, but I won't, that's not what I'm here to talk about another time. I'm happy to come back. And there's so much that could be said about the work that we do in Indian country, and I think it can inform a lot of the other, in the context in which all of you work. But right now, I've worked for the last 25 years for an organization called the Intertribal Council of Michigan. It is a tribal organization, which means it's a nonprofit, but our board of directors are composed of elected officials from the 12 federally recognized tribes in Michigan. We use we've had multiple SAMHSA grants, and we've had grants from SAMHSA since it opens its doors. But we use a model for intervention and treatment for people with substance use disorders, including opioid use disorder. We are seeing certainly a rise in that. The data we have for American Indians in Michigan, I don't have that in my PowerPoint, but I can provide it, shows that we have a opioid overdose death rate of twice the rest of the population. So our community is significantly impacted by this. But we also don't want to forget that our community is also significantly impacted and continues to be significantly impacted by the addiction to alcohol, some of the related problems associated with alcoholism, and we still have high death rates from cirrhosis and associated illnesses. So we have developed over years a model for intervention that includes both indigenous approaches to healing, and some of those I have listed there. We do things like sweat lodges, talking circles, tribal teaching sessions, song and dance, regalia making, language restoration, all that are sanctioned by the local tribal community. We also use other evidence-based practices that are
appropriate for our communities. I think sometimes we talk too broadly about evidence-based practice without really breaking it down. Where has that evidence been derived from? Who is the population that there's evidence that that is effective with? I think that is really a serious problem in our conversation. And that's a whole lecture in itself, and I would love to talk about that. But we do use things like cognitive behavioral therapy when it's a good match. We use motivational interviewing, and we use contingency management. Those are things that we've used within our programs. Again, I'm going to show a story. So this story talks about, well, speak for itself.
I grew up in Peshabi Town. I was fortunate to have my grandparents during the early part of my life. My grandmother was an avid basket maker, and my grandfather was an artist, wood sculptor, and businessman. I have precious memories of those early years, and it has contributed to who I am today. In 1967, I was born to an Odawa mother and Irish father. Our family suffered from many of the same issues facing other Native families. After the death of my grandparents and divorce of my parents, life changed. Alcoholism replaced what we once had. At 11 years old, me and my little sister were taken away and placed into foster care. After a few months, we went to live with our dad. All at once, I remember feeling angry, sad, and lost. At 15, I went to live with my mom. She stayed sober at times, but when she drank, she said or did things that hurt our feelings. I remember one time when we were in the kitchen talking. Everything was swirling inside me. Finally, I asked, "Why can't you stop drinking? Why can't your love for us be enough?" She said, "Joanne, I love you, and you are a good daughter. There isn't anything you can do that will make me stop drinking. I'm an alcoholic. I'm the one who has to stop drinking." In that moment, time stood still. Then it hit me. I didn't have the power to change her. She had to be the one to change. Immediately, my anger turned into curiosity, and I began asking my mom about her life. Her stories about childhood hurt and suffering opened up respect and forgiveness in me. Mom always encouraged us to find joy, even through the hard times. She loved to laugh and taught me many life lessons. At 19 years old, when I realized I was going to be a mother, I asked myself, what kind of mother am I going to be? What kind of Native woman am I going to be? I knew I didn't want the crazies. I wanted to be the best person I could be and to give my sons a better life. For over 20 years, I have been learning the teachings, songs, and ceremonies of our people. The Three Fires Society taught me not only about who I am, but that healing and forgiveness are mine, if I choose. My children are my inspiration. I want them to know who they are and to live their best life.
I'm just going to go forward. Martha worked for many years as a coworker, a collaborator, and she has now passed on. But we have a new generation, and actually we're making stories about the opioid issues in our community too, and those are going to be coming out very soon. All of our work emphasizes community ownership of issues and solutions. So that also is a lecture in itself, how to do that in communities, how to work effectively with people, and bringing those ideas to the forefront. All right, so we have enrolled 11,000 individuals. Most of them are American Indian, but we recognize that the issues of substance abuse are family issues. So if a person has a non-native spouse or partner, we enroll that person too. So we don't. The vision that we work from is that our spiritual strength, the spiritual strength of our ancestors, will live on in the hearts of our children. And actually, that's my grandmother, and that's my daughter, and that's the Mount Pleasant Indian Boarding School. So this is the reality that we work from. And I will show you another story because these stories are awesome.
I was born to John Kejate and Frida Cobb on August 19, 1952 in Muskegon. I was their pride and joy. At 9 months old, my dad died from appendicitis. My young grieving mom took me to live with my grandmother in Peshabi Town as she continued drinking alcohol to numb her loss. I felt loved and happy with my grandmother in our Odawa community. Braiding my hair, she would say, "Go to school and be proud you are Indian. It cannot be taken away from you." In school, I loved reading and always read above my grade level. Being the only Indian in my class, I was called names and felt discriminated against. Eventually, my mother married a white man who was physically abusive. At 7, I helped raise my sister and 2 younger brothers. When the drinking and fighting began, I would take my siblings down the railroad tracks at night to my grandmother's, our safe haven. At the age of 10, we were taken away permanently because of the alcohol and abuse. My sister and I were placed with Vernon and Joyce Brandt. Then I was moved to a Catholic orphanage because of my baptism. I used to get up at 5 a.m. with the nuns to attend Mass and pray every day. For 5 years, I was moved around, from orphanage to foster home to a locked Catholic school, then back to my original foster home. I set a precedent for Catholic children to be placed in non-Catholic homes. It felt like nobody wanted me and I didn't fit in. Nevertheless, I continued to excel in my classes and prayed daily. In 1970, I graduated from high school with honors, and I was accepted at Michigan State University. 2 years later, I dropped out and moved to Peshabi Town. During this time, I left Catholicism and began looking for my traditional spirituality. All my life, I always knew I was Indian, and I needed to go home. Within the first few years, through ceremony, I got my Indian name, Bimosadnawa Inkwe, middle way woman. It means I have lived in 2 worlds, Indian and white. I know how to help our people go back and forth, and also I am middle way between the spirit and physical world. My name helped me understand my childhood struggles and my purpose. Today, I continue to attend ceremonies, offer tobacco at sunrise every morning, and dance at our powwows. In 1982, the Creator guided me to my adopted parents, Hilda and Jerome Surratt, who are my primary traditional teachers. My dreams guided me to be initiated into the Medewan, and for the first time in my life, I knew where I belonged, and that it could never be taken away from me. I remember one dream where I was walking through a glass corridor covered with a teepee that connected 2 buildings of a college. The dream guided me to continue learning not only our traditional ways, but to continue learning in the educational system. Afterwards, I went back to school to finish college. In 1995, I received my bachelor's degree in psychology with a minor in Indian studies, and in December 2011, I received my master's degree in educational administration. Bimosadnawa Inkwe Indijnakas. With the Creator's help, I'm ready to help my people. We need to walk in both worlds to succeed. We need you as an Indian person to obtain an education and for you to learn and remember our traditional teachings.
We have made about 55 of these stories. So these, and we're also doing a study on the storytelling as an intervention. So I'm going to go to and close with this. You won't hear a lot of my words, so if I be happy to come back sometime.
One morning I woke up and I heard my brother crying. He was screaming so loud you thought someone was dying. "Mom, Dad," he screamed, but there was no use trying. They weren't around. I ran outside and saw he'd had a pretty bad crash. His bike was in the ditch, down his arm a bloody gash. He looked so pitiful just sitting there in the dirt amongst the trash crying, "I want Mom and Dad." I picked him up and started running toward my uncle's up the way. It started raining and got real dark. You could barely tell it was day. My brother cried and asked, "Sister, where's Mom?" I didn't know what to say, when the truth is, I don't know. When my uncle saw us coming, he ran into the yard. He took my brother from me and he held him in his arms. When he saw my face, I could tell he was alarmed. And he said, "What happened? Did you fall too?" "Uncle, I'm so tired of wondering why. Why do they drink? Why do they do drugs? Why do they leave us? Why?" He said, "Sister, it's hard to explain." And I said, "Uncle, try." And then he told this story.
Once this land was teepees as far as you can see. The water was clean, the land pristine. We were where we were meant to be. Then strangers came across the sea and brought with them their disease. Our people cried and prayed and sang, but it brought them to their knees. Imagine that your family, and most of all your tribe, what if most of everyone you love suddenly got sick and died? And before you even had a chance to bury them and mourn, the strangers came and took away the land where you were born. And you wondered if your parents even cared as they stole you and your brother away, or if they'd been so beaten down they had nothing left to say. And then at school, they cut your hair and beat you if you spoke. The language that Creator gave our people when earth awoke.
We will rise up from the darkness. We will overcome the pain. Warrior spirits live within us. We shall remain.
Sister, I'm not trying to tell you that your mom and dad are okay, or that they are not responsible for the choices that they've made. But but you see this bloody wound on your little brother's arm. If we don't clean it, it won't heal, and it'll do all kinds of harm. Those deep wounds of our ancestors still bleed within our hearts. When we remember all they've done, that's where the healing starts. So every morning when you wake, you pray this prayer out loud. Creator, help me live in a way that would make my ancestors proud.
We will rise up from the darkness.
Don't you forget this. You can be anything you want to be.
We will overcome the pain.
Just work hard, never give up. Perseverance is the key.
Warrior spirits live within
Strength,
us.
dignity, honor, that's all in your family tree. So hold your head up high and know that.
We shall remain. We will rise up from the darkness.
Creator, help me live in a way that will make my ancestors proud.
We will overcome the pain.
Creator, help me live in a way that will make my ancestors proud.
Warrior spirits live within us.
Creator, help me live in a way that will make my ancestors proud.
We shall remain.
Little brother, we will rise up from this darkness. Little brother, we will overcome the pain. Remember, warrior spirits live within us. We shall remain.
I thank you for your time, and we are out of time, and I will turn it over to you and
Hi, good morning. I'm speechless because that was the talks that we've heard this morning are so powerful. And so there's a line that comes to me, and it's like I feel like I have to take off my shoes for I'm standing on holy ground. And so I have a PowerPoint to talk about risk and resilience in prenatal alcohol exposure and child welfare. But in some ways, the words I'm going to present feel really, in some ways, hollow compared to everything we've heard this morning. I also recognize that I'm the only thing standing in between you and lunch. So that hasn't escaped me. So I'm going to look to Joe and Emma for guidance, how long you want me to go, and I'm happy to follow your lead. And I just a big thank you to Joe and the Dean of the School of Social Work for just inviting me to be a part of this really special morning. So I take care of children in the fetal alcohol clinic, and what I'd like to think about with you over the next maybe 20 minutes or so is how we think about risk, and then more importantly, how we promote resilience in these families who come, in these children who come from families that are really complex. And what I'd like to invite us to do is to look at these children and their families through the eyes of compassion. And I think what we've heard in the really eloquent presentations this morning is that that the experiences of children in these families and the families themselves are sort of multifactorial and multi-generational in their experiences of trauma, abuse, neglect. And after I did my developmental fellowship in child behavior and development, I did an infant psychiatry fellowship in New Orleans to look at how do children grow and develop in the context of the caregiving relationship. And that work was done with Charlie Zena, who's a very well-known child developmental and infant psychiatry researcher in New Orleans. And he worked a lot with children in the foster care system. And he said to me, in the heart of every parent, even in the heart of a maltreating parent, is the desire to do right by their child. And so if they are not able to live up to the fullness of their humanity, if they're not able to live up to the fullness of their interiorized desire, then it means that somehow they have been failed, and it's up to us to help them. And so over the next few minutes or so, I'd like to talk about the developmental vulnerabilities of children in the child welfare system with a specific focus on the role of prenatal alcohol exposure. I'd like to share with you guys our diagnostic approach, not because I'm trying to turn you into developmentalists, but because you guys are in the front lines. You guys are seeing families in your work as clinicians, in your work as foster care workers, as child protector, in the child protective services. And you're seeing these kids much earlier before I ever get to see them. And so if you have a sense of what the dysmorphology and what the presenting symptoms are, you will have a sense of how to advocate for these kids and bring them to attention. We'll talk about the multivariate neurobehavioral vulnerabilities of children with prenatal alcohol exposure. And I'd like to end with a window for hope. So how can we help these kids and their families to really help optimize their developmental potential? And so I'm going to start with the Delta Airlines view, the view from 30,000 feet above for kids in the child welfare system and those who have had an experience of prenatal alcohol exposure. And the 30,000 feet view is that it's really complicated, and you guys are in the front line, so you know this way more than I do. And so when I see these kids, I'm asking the question if prenatal alcohol exposure is related to the child outcome, whether that's developmental disability, whether it's emotion regulation problems, whether it's executive function problems, whether it's aggression and behavioral dysregulation. But you know as much as I do that that pathway from exposure and risk to outcome is multifactorial and complicated and is associated with many prenatal experiences, generational experiences of abuse, trauma, neglect, genetic differences, perinatal experiences, including whether that child was born preterm, and most importantly, what is most relevant to us in this audience are the postnatal experiences. So if there's abuse, neglect, trauma, if there is caregiving instability, if there is ongoing substance abuse, which affects the caregiver's relationship to the child. All of this is complex, and we know that these systems and these pathways are even exacerbated and made much more complex for families who live with poverty, mental illness, and ongoing trauma. And so this is data that we've heard throughout the morning that children of child welfare are, in the child welfare system, are vulnerable. Over 5.5 million children were reported for abuse and neglect. That's probably an outdated number. And of those, 64.5% were victims of neglect, 17% victims of physical abuse, 10% sexual abuse, 7% have a history of psychological and emotional abuse, and 2% have medical neglect. So these are children with multiple levels and multiple experiences of trauma, many of whom would score positive on the ACE indices, so adverse childhood experiences. When we think about how substance abuse affects these children, we know that there's a very high association of children in the child welfare system with a history of prenatal exposure to drugs and alcohol. And the impact of substance abuse and alcohol on the developing child exerts its effects both prenatally in terms of direct teratogenic effects on the developing brain and the developing fetus, which we'll talk about, and postnatally. So for parents who continue to have experiences of difficulty with abstinence and sobriety, parents who are continuing to have substance use and abuse, it affects the parent's ability to function effectively in the parenting role. And so we've heard that throughout the morning. In terms of how substance abuse and alcohol affects the developing brain, when we think about these prenatal experiences, we often know that there is a history of polysubstance abuse. These are not happening individually in isolation. The meta-analytic studies of marijuana have shown that children with a history of cannabis exposure have over time impaired cognition, learning, memory, and especially difficulties in self-regulation. It's a very similar picture for children with prenatal cocaine exposure, lots of difficulties with self-regulation. Similarly with methamphetamine, and with alcohol use, again, impairments in cognition, learning, memory, increased impulsivity, they can have growth restriction, and it's the most common preventable cause of intellectual disability. When we think about the postnatal environment in families who are exposed to substance abuse, we know that children in foster care have a history of disruptions with their primary caregiver. And we've heard throughout the morning that these children have often multiple disruptions and that there's multiple changes in placement in foster care. Histories of abuse, neglect, and parental substance abuse are often associated with lots of experiences of family instability. For the child, it's an experience of a violation of trust. They have had a violation in their experiences of consistency in caregiving. It increases the risk for insecure attachment and especially disorganized attachment when there is experiences of maltreatment. And long term, those disorganized attachments and instability in the caregiving relationship provides an increased risk for later social, emotional, and behavioral problems. And often these kids come into our care and come to our attention because of the behavioral vulnerabilities they're presenting. And so when we see these children in the child welfare system, they have many, many vulnerabilities. And I know that you are familiar with this. Long term, they have an increased risk of substance abuse. They have a history of attachment disruptions. They can present very often with developmental delay, especially when there's been a long-standing history of early pathogenic care. They present with aggression. They can have academic difficulties, attention problems, behavior problems, speech and language problems, and executive function disorders. What is really tricky about this presentation is what I'm going to call sort of the equifinality, the difficulty with equifinality. And I know that we have some social work students in the audience, and so I know we have a mixed audience, but just to remind ourselves about equifinality and multifinality. So equifinality means that there are many different things which can cause one single outcome. And multifinality is that you have one cause which leads to many different outcomes. And so for us, we see these kids who come to us because of concern about behavior disorder. However, thinking about this from an equifinality perspective, that symptom of behavior problems, dysregulation, aggression, executive function disorders, has multiple etiologies. Those kids can present with behavior problems because of a history of substance abuse. They can present with behavior problems because they've had a history of abuse and trauma. And they can present with those behavior problems because they have a medical diagnosis of, for example, something like autism. Contrast that with a multifinality pathway. You have a child with one exposure, for example, alcohol exposure, but the way in which that exposure manifests behaviorally, symptomatically, pathognomically, phenotypically is different. You can have alcohol exposure, but that child presents with a coordination problem and fine motor delays. They can present with a learning disability, with memory problems, and difficulties with math and reading. And they can present with behavior problems with aggression and impulse control disorder and conduct symptoms. So again, when we see these kids, when we see them presenting with a behavior problem, we need to think that there are many etiologies that are contributing to that presentation. And when we see a child with prenatal substance or alcohol exposure, we need to think that there are many outcomes that can be associated with that one exposure. And so when we think about what are the pathways to developmental risk, is it biology or an environment? If you have a child with prenatal alcohol exposure, is the psychopathology due to direct neurotoxic effects on the developing brain? Or is it that you have prenatal alcohol exposure? It causes direct neurotoxic effects on the developing brain, and that child with quote unquote brain damage or impaired self-regulation or neuronal regulation causes a disruption in that early parent-child dyadic caregiving relationship, and that's what leads to the psychopathology. Or is that you have a history of prenatal alcohol exposure? Likely that's also associated with postnatal ongoing alcohol exposure, substance exposure in the caregiver, and that causes dyadic disruptions, and that leads to psychopathology. And the answer is probably yes, and all of the above. It's probably not one of these pathways, but probably all of them are a multiplicity, or all of these acting in conjunction with each other. And so to bring us back to our Delta Airlines 30,000-foot view, the story is complicated. And so to try to simplify this story with prenatal alcohol exposure does cause direct neurotoxic effects on the developing brain, and I'll show you how, and that does really lead to adverse maladaptive child outcomes. But that those influences on the developing brain have other multifactorial moderators, including prenatal, perinatal, and postnatal factors, and can be exacerbated by families living in poverty, families with ongoing mental illness, families with ongoing trauma, and families with ongoing substance abuse. And so I'd like to spend a little bit of time thinking about our diagnostic approach to children with FASD, specifically around our assessment of dysmorphology. Because if those of you in the audience who are in the front lines who are seeing families have a sense of what to look for, you will know who would need to be referred for a more in-depth evaluation. And so when we think about fetal alcohol spectrum disorders, it's actually an umbrella term encompassing 4 different disorders. The most severe is fetal alcohol syndrome. There's also partial fetal alcohol syndrome, alcohol-related birth defects, and alcohol-related neurodevelopmental disorder. These 4 different disorders under the umbrella of FASDs are diagnosed by basically the presence of 5 characteristics. And so when we see kids in our fetal alcohol clinic, we look for the presence of these 5 symptoms, and that is confirmed alcohol exposure. Do they have the presence of facial features? Do they have evidence of growth restriction, which is height or weight less than the 10th percentile at any point in time? Do they have evidence of CNS abnormalities, which is microcephaly, characterized by head circumference less than the 10th percentile? And do they have a complex pattern of cognitive and behavioral abnormalities? And so the first and most important piece of information is whether there was prenatal alcohol exposure. This is a disorder of teratogenesis. You cannot have an alcohol-related diagnosis unless there was confirmed prenatal alcohol exposure. And that is often the most difficult piece of information to ascertain. So very rarely, really, really rarely do we have the biological mother available. And when we do have that biological mother available, when that birth mother is present in the visit, it is really, really special. And I tell that to the mother and I say, you know what, this is the most special moment because you are here, because you can tell us something that no one else on the planet can tell us. You can tell us what your pregnancy was like. You can tell us with certitude if there was alcohol exposure. And we ask this not because we have any intention of vilifying you. On the contrary, it takes a tremendous amount of courage. It takes a tremendous amount of transparency and a tremendous amount of humility to acknowledge prenatal alcohol and substance abuse. And so I have to say, when I have a birth mother there and she's able to tell me this information, it's a take off your shoes for you're standing on holy ground kind of moment, because no one else on the planet can tell me that information. And what I tell this mother is that you have something that is so precious and priceless to me as a diagnostician, because when I see your child and we think about that equifinality pathway and we think he's got behavior problems and I don't know what causes it, and you are the only person who can tell me if this could be related to prenatal alcohol exposure. And that's priceless because that guides my treatment, and that helps me to know prognosis, and that helps me to know what I need to intervene on for your child to help him reach his developmental potential. And so for lots of reasons, birth mothers may be reluctant to share in that history, and often it's because of stigma. And so the more we can destigmatize the exposure, I think we will allow birth parents to be much more transparent. Whenever we're asking about exposure, when we think about the neurotoxic effects on the developing brain, there's the epidemiologic studies have suggested that there's a threshold. So more than 4 drinks at a sitting is considered binge drinking. Binge drinking twice in the pregnancy is considered the neurotoxic threshold to affect the developing brain. And so when I'm with birth mothers, I will ask them, so before you knew you were pregnant, how much might you have to drink in a sitting? And I really highlight that because most drinking during pregnancy happens before a woman knows that she's pregnant. And so to be able to hold that and say, you know what, if there was exposure, we don't think about this as your fault. There is not culpability because culpability implies intentionality. If you didn't know you were pregnant, there was no negative intentionality. And so what I'm just asking for is your recollection and your truth, because that is really priceless and precious information. And so the way I ask the question is, before you knew you were pregnant, how many drinks might you have had in a sitting? And I would say 5 to 10 drinks, 10 to 15, 15 to 20. So we start the bar high. And if we say 5 to 10 drinks, then it gives permission for someone to say, oh, yeah, maybe I had 7 drinks at a time. It was the holiday time and we were having a good time. Or no, I only have 4 drinks at a time. And so that gives us a sense of what the exposure was. if we don't have a biological mother available, which is often the case, we have to get lots of information. And often you guys who are social workers are really priceless source of information for us. We look at birth records, we look at medical passports, we look at the CPS records, we look at the court records. We look to see if there's a history of the mother having a history of alcohol use and alcohol treatment in the past. What's often tricky is that these are children who are placed in multiple foster care placements, and so there's the risk of the telephone game where the information gets passed on from person to person and then is not very reliable. So we have to have a high index of suspicion. We look for growth, height or weight less than the 10th percentile at any point in time. And then we look for evidence of CNS abnormalities, either microcephaly or evidence of cognitive or behavioral deficits characterized by developmental testing and neuropsychological testing. In terms of the facial features, these are the three things that we look at. We look at small palpebral fissures and we measure them. That's really hard to do. We look at evidence of a smooth philtrum and a thin upper lip. And so this is what you guys can identify. One of the things I want you to take home from this is that the effects of alcohol on the developing brain, and especially on the developing face, are dependent on dose, duration, and timing. When we think about the embryologic development of the developing fetus, the face, the teeth, the palate form largely within the first 12 weeks of pregnancy. So you will get facial features associated with prenatal alcohol exposure if the mother was drinking in the first 12 weeks of pregnancy. If the mother was drinking after the first 12 weeks of pregnancy, you will not have an affected face, but you will have an affected brain. And the reason that's important is because you can have a child who looks phenotypically normal, who does not have any phenotypic characteristics of FAS, who has basically a non-dysmorphic face, but who has all the behaviors and the brain deficits associated with prenatal alcohol exposure. And so those are often the kids who are missed because they look normal. And so what we do when we're looking at the presence of facial features is we measure the eyes and we look at the presence of the lip and the philtrum. And so when we're looking at the lip and philtrum, we're looking really at the morphology of that upper cupid's bow, we're looking for what I call the Michigan M, and then we're looking for the height of those philtral columns. Scores of 4s and 5s are atypical and dysmorphic and considered FAS faces. And we need two facial features in order to give them an FAS face. I would say for those of you in the front line, if you see a child with one facial feature, that's enough to merit a referral to our clinic so that we can do a deeper dive. What's also really important is that you have to have a cooperative patient in order to get a really good assessment of that lip and philtrum morphology, which makes it really hard to do this in infants and toddlers. So try telling an infant and toddler not to smile, don't frown, stay still, and I'm coming close to measure your eyes. It's awfully difficult. And so seeing these facial features in little people is really an exercise in patience. I know that my time is running out, so I want to talk really briefly about the effects of alcohol on the developing brain. Basically, there are several areas of brain development that seem to be particularly vulnerable to the effect of alcohol. Those include the cerebellum, and that can manifest as difficulties in bimanual coordination, difficulties in balance, problems with verbal learning and memory. The basal ganglia seems to be affected, so these kids often have difficulty with motor control, difficulties with executive function and attention and spatial memory. The hippocampus is particularly vulnerable, so those have difficulties in working memory. And so often the narrative that parents will say is that, oh, I teach him something and he doesn't remember, and I have to teach him the same thing over and over again. And so these are kids who can't consolidate memory. They can't learn from experience. They have to be taught the same thing over and over again. It can be frustrating for families. The corpus callosum connects the right and left hemispheres of the brain, and these children can often present with deficits in bimanual coordination, deficits in verbal learning, executive function, emotional regulation, and the big issues with these kids is deficits in their frontal lobe function. And so the prefrontal cortex is associated with areas of higher order cognition, executive function, and attention. And so these kids often have lots of difficulties in self-regulation and attention control. There are certain neurotransmitter pathways that are affected in FASD, both the dopamine pathways, which are really associated with like reward and pleasure seeking. And so these kids are really driven by sensation seeking and reward seeking. The serotonergic pathways are also affected. And so these kids have lots of difficulties with mood and memory and sleep. We talked about some of the multifactorial deficits associated with prenatal alcohol exposure. And the thing that I really want to highlight is that these kids get into trouble not because they have a smooth philtrum, not because they have a thin lip, but because they have difficulties with attention and impulsivity, self-regulation, because they have really, really poor metacognition and really, really terrible judgment. They don't know how to make choices in a way that is adaptive. And so that's what we need to address. Part of the challenge also of making this diagnosis is that in infancy, the symptoms and the neurobehavioral impairments are pretty nonspecific. They can have developmental delay, fine motor problems, gross motor problems, self-regulation behavior problems, attention and language deficits. But again, thinking about that equifinality pathway, we also see these deficits in kids who are born prematurely. We see these same deficits in kids with early presenting signs of autism. We see these same symptoms in kids who have had a history of trauma, abuse, or neglect. So again, really, really difficult to identify these neurodevelopmental differences in infancy. Often the specificity of the neurobehavioral impairment emerges later in school age. And so as we're thinking about these kids, in the absence of microcephaly, it's really difficult to quantify these deficits in infancy. Significant levels of delays are often not apparent in early childhood. And so really it invites us to really have a low index of suspicion and provide ongoing developmental surveillance. I want to speak one brief minute about this question of trauma. So as we've talked about and as we've seen from like the Delta Airlines view, that these issues do not exist in isolation. So children with prenatal alcohol exposure also often have concomitant exposure to trauma, and trauma exerts its effects on the developing brain. And so Dan Siegel has a really lovely, concrete example of what, sort of brain development and trauma looks like. And so if we took our hand, and this was sort of the image of the developing brain where the fingers are our prefrontal cortex and our thumb is our amygdala and our limbic system. In a well-functioning, non-traumatized brain, you have close connections between the prefrontal cortex and the limbic system. And so you can operate from a top-down approach, and you can operate really thinking at a level of cortical control. When you have trauma and the exposure of trauma to the developing brain, Dan Siegel talks about this as flipping your lid. And so really what happens is you have a disconnect between your prefrontal cortex and your limbic system. And then you're operating really at the level of survival. You're really operating at your lower levels of brain function. And you're no longer operating under that place of cognitive control. And so we know that kids with a history of trauma often have an overregulated response to threats, a hyperactive sort of cortisol response. And so they live in environments of just sort of threat and hypervigilance. In just like one last 2 minutes, I'm just going to fly through, if that's okay, Emma, just sort of how do we think about these kids and how do we think about promoting a sense of resilience? And a lot of that was presented already this morning, so I feel like I'm just reiterating everything that all of the really, really thoughtful presenters have said before me. And one of the things I really want to highlight is this idea about early intervention. And so if we think about brain development and we think about the amount of synapses that are expanding and connecting over early infancy, those are really exploding in the first 6 years of life and are formed by the quality of the early connections. If we think about what are the different parts of the brain that are developing, so much of the organization of the brain is happening prior to preschool. And so really there is an onus of responsibility if we want to optimize early brain development to intervene early. We know that the quality of early experiences and relationships affects the development of the brain, especially in the organization of the limbic system, which is the part of the brain responsible for emotion regulation, and that early caregiving experiences that are maladaptive interfere with the child's, with that regulation of the limbic system. And so when we think about work from a policy standpoint, I want to remind us of the work of James Heckman, who is a Nobel laureate prize-winning economist, who talks about the return on investment. And so when we invest in infancy and early preschool period, we get the greatest return on investment. And so I'd really like for us to think about this as applied to children in the child welfare system. And so basically the big things to think about in terms of optimizing outcomes and promoting resilience is to think about early diagnosis, early prevention, and early intervention. So diagnosis, the best outcomes are when we can diagnose FAS before 6. So to have a high index of suspicion in kids who live in environments of trauma. And so who are the high-risk populations? Well, we've heard about them all this morning. Children of substance abusing mothers, children in foster care, children who are internationally adopted. Those populations of children have a 10-fold higher association of prenatal alcohol exposure. Think about prevention. If we can identify mothers who are drinking during pregnancy and get them to stop, mothers who stop drinking during pregnancy have those children have better outcomes than mothers who continue to drink during pregnancy. So every day a woman stops drinking is beneficial for her developing fetus. To think about early intervention, as we all know in this audience, that stable, nurturing caregiving is really the foundation for healthy social, emotional, and cognitive development. And so that means an absence of exposure to violence. It means minimizing the number of placement changes and caregiving changes. It means accessing early intervention services and IEPs so that they can get school-based services. And it means establishing as much as we can a permanency plan as early as possible. We know that early experiences exert effects on the developing brain. And so what happens when you've had adverse early experiences? Is there the potential for malleability? And I would say yes. There's some really wonderful work happening out of the University of Delaware, out of Mary Dozier's group. And she talks about the capacity of the human brain to reorganize in terms of its capacity for physiologic self-regulation. And so what she did was she looked at cortisol regulation, which is a measure of like stress reactivity in children who are in foster care and then children who are basically non-exposed. And then she provided them a relational intervention. And so these are the children in foster care who basically have this high level of cortisol secretion throughout the day. They never downregulate. We see a much more normative and adaptive stress response in children who are not trauma exposed and who are not in foster care. And in the green, we see the children who had a relational intervention. And so for those children who had a relational intervention, they actually had a physiology that looked pretty identical to those who were never exposed, who had no trauma. And so what this tells us is with really thoughtful, trauma-focused relational interventions for children who have had histories of abuse, neglect, trauma, and adversity, you can actually reprogram the developing brain and reorganize really deep subcortical neurologic functions. You can reorganize their physiology in a way that looks adaptive. And so what her intervention focused on was reorganizing the environment, helping the caregiver reinterpret the child's alienating cues, and provide an environment of consistency. And so for us who work with these kids, I think the message is the same: to provide an environment to help them regulate, develop a self-regulatory capacity, so to simplify and structure the environment. How do we reinterpret the child's alienating cues to respond and not react? And then to provide consistent nurturing care. And so for children in the foster care system, we want them to have an internalized experience where they say, this is my favorite place inside your hug. There's some really wonderful work from the Circle of Security Project that basically talks about how the foundation of healthy adaptive emotional development is really found in the context of really supportive, nurturing, consistent, responsive caregiving relationships. For children who have experienced abuse and trauma and neglect, their environment and their secure base has been completely disrupted. So they don't know what's safe anymore. And so their behavior, if they don't know what's safe, they are going to respond in a way that is traumatized, in a way that reflects their interior confusion. For a parent who has ongoing substance abuse, basically we need to provide them support, encouragement, and help so that they can put their child first. And so hopefully through this multi-level collective work on lots of different levels, hopefully this is what we can provide for children working together, where they can have this internalized experience, where they can say, this is my favorite place inside your hug. Thanks so much. Thanks, Emma, for the extra time.